Hello students, good evening everyone. I'm audible and visible to all of you guys. Please update me in the chat box. Audio and video is clear to everybody. Thank you. So welcome to the next session. That's going to be OBGYN revision part 2. So we have already discussed the main topics so far in the part 1. We have already discussed the ectopic pregnancy, the postpartum hemorrhage, the antepartum hemorrhage, the hypertension in pregnancy. So in revision part 2, we'll be focusing more on a gynae part as well as the remaining part that was remained left in an obstetrics. So without any further delay, let's begin with the first question of the day. Now, a patient presents in a labor room at term pregnancy. The clinical pelvimetry was performed. She has an oval-shaped pelvis with an antero-posterior diameter at the inlet more than the transverse diameter. On abdominal examination, there is a subumbilical flattening and the fetal heart is auscultated on the flanks. The most likely kind of the pelvis is. So whenever a clinical case is in front of you with the following finds, the finding number first, that is to be oval shaped pelvis. Okay. The number second, the antero-posterior diameter is more than the transverse diameter. The antero-posterior diameter is more than the transverse diameter. Followed by that, on abdominal examination, there is a subumbilical flattening and the fetal heart is auscultated on the flanks. So when a fetal heart is auscultated on the flanks, it is suggesting of the occipito-posterior position. That means the occiput is on the posterior side. And the classical type of the pelvis, write down in the chat box, the classical type of the pelvis associated with the fetal heart auscultated on the flanks, the oval-shaped pelvis, and the antero-posterior diameter more than the transverse diameter. Your answer is going to be very good. In the chat box, yes, that's going to be anthropoid pelvis. Okay. Now, my dear students, we have a different types of the pelvis. This classification is called as Caldwell's classification. Now, these different types of pelvis, we're gonna study that what kind of the delivery will be seen and what are the classical features of each of the following pelvis. Now, if we talk about the most common position, that is gonna be for the normal vaginal delivery, the best one will be occipito-anterior. So 80% of these occipito-posterior. First of all, what exactly is the occipito-posterior? So it simply means when the occiput is on the posterior side. What is occipito-anterior? So occiput on the anterior side. Now 80% of occipito-posterior will turn to 80% of occipito-posterior will turn to occipito-anterior. Okay. And 80% of occipito-posterior will turn into occipito-anterior and they will be delivered with a normal vaginal delivery. Now this rotation from occipito-posterior to the occipito-anterior, it depends upon the type of the pelvis. Now that means if 80% of occipito-posterior are turning into occipito-anterior easily, that means it's suggesting of a pelvis which is somehow like a rounded cavity, and this one is going to be the most common type of pelvis. So write down in the chat box what type of pelvis is that with a rounded cavity. First of all, with a rounded cavity, and it's going to be a most common type or the best type of the pelvis. That is going to be the first one, which is called as a gynecoid pelvis. Okay, so occipito-posterior easily turning into occipito-anterior with a rounded cavity type of the pelvis is going to be a gynecoid pelvis. Now 15% of occipito-posterior, they are remaining occipito-posterior only, because the type of the pelvis over there, the cavity over there, it is a oval shaped cavity. So oval shaped will be which type of pelvis? That is going to be the anthropoid pelvis. Now in anthropoid pelvis, how will be this delivered? Now if this is occipito-posterior only, this is the face of the baby, this is the pubis area. The type of the delivery we have is face to pubis delivery. The type of the delivery in an anthropoid pelvis, we call it as face to pubis delivery. Now sir, 2 to 3% of occipito-posterior, they try to convert to occipito anterior, but they rotate partially, but they get stuck. That stuck is called as a deep transverse arrest. And this deep transverse arrest is seen in which type of pelvis? The classical shape of the pelvis is a triangular shaped pelvis or the heart shaped pelvis. That is going to be the triangular shaped pelvis or the heart shaped pelvis. Is that clear? That is going to be heart shaped pelvis. Clear to everybody? Now let's understand the classical features of each type of the pelvis. So followed by the shape. अगर oval shape दिया हुआ है question में, if oval shape is mentioned, that is going to be the gynecoid pelvis. If rounded cavity, sorry, if oval shape is mentioned, that is going to be anthropoid pelvis. If rounded cavity is mentioned, that is going to be gynecoid pelvis. If triangular shape or heart shape is mentioned, that is your android pelvis. And if transversely oval, that is going to be a platyploid pelvis. Now let's understand each type of the pelvis. Now what are the 3 points? Remember first, whenever the antero-posterior diameter is more than the transverse diameter, the type of the pelvis, it's going to be a anthropoid pelvis. And which type of delivery? So face to pubis delivery. Face to pubis delivery. Now let's begin with the each type of the pelvis. Now first one, as we have already discussed, the gynecoid pelvis. It's the most common type of pelvis. Gynecoid pelvis, it's the most common type of pelvis. Followed by that, the cavity is a rounded cavity. Rounded cavity and normal vaginal delivery. Yeah, O is occipito anterior. The best type, that is the gynecoid type. Number second one, the anthropoid pelvis. Just now we have discussed, this is going to be the second most common type of pelvis. This is going to be the second most common type of pelvis. Okay, followed by that, so the shape of the pelvis, it's going to be oval shaped pelvis. It's going to be a oval shaped pelvis. And the type of the delivery that is seen with anthropoid pelvis, it's a face to pubis delivery. It's a face to pubis delivery. And do remember that antero-posterior diameter is more than the transverse diameter. It's more than the transverse diameter. Next to that, so type of the pelvis, that is going to be an android pelvis. This android pelvis, it's called as a male type of pelvis. It's called male type of pelvis. The shape of the cavity, it is triangular or heart-shaped pelvis. This is going to be heart-shaped or triangular shape. Followed by that, this type of pelvis, it is spacious posteriorly but narrow anteriorly. That is why when from occipito posterior, the presentation converts to occipito anterior, but in the midway it gets stuck. And that stuck is called as a deep transverse arrest. That stuck is what we call as a deep transverse arrest. So it's spacious posteriorly. Spacious posteriorly, but narrow anteriorly. But narrow anteriorly. And deep transverse arrest occur in this type of pelvis. Deep transverse arrest is seen with this type of pelvis. Clear, bache? And do remember one thing, how do we manage this deep transverse arrest later on? So better is we first go with the forceps, but best with the cesarean section. Clear? So that was all about the gynecoid pelvis. That was all about the anthropoid pelvis and the android pelvis. Now the last one, that is platyploid pelvis. So first thing, so it's the rarest one. It's the rarest type of pelvis. Followed by that, the shape of this pelvis, it's transversely oval. You can see in the picture. It's transversely oval shape, and this is associated with which type of presentation is seen? Face presentation. What is face presentation? It's a type of a cephalic presentation when the face is touching the lower pole, or when the face is touching the lower uterine segment. Face is touching the lower uterine segment. Clear to everybody? Yes? Very good. Now, that was all about the different types of pelvis. That was all about the different types of pelvis. Okay. Now, if you have one more question over here, if inside the question it is mentioned that antero-posterior diameter, it is less than the transverse diameter. Antero-posterior diameter is less than the transverse diameter. Think of a platyploid pelvis. Think of a platyploid pelvis. Then other things, oval, rounded, heart-shaped, and the last one, transversely oval-shaped pelvis. Now, the next question, if given, just on the shape of the pelvis, a patient taken up for the normal vaginal delivery who was in labor, the child had a vertex presentation, but position is occipito-posterior. The position is occipito-posterior. The head rotated partially, but went into the deep transverse arrest. Which of the following pelvis type can lead to this condition? Which of the following pelvis type can lead to this condition? So classical hint, deep transverse arrest. So what will be your answer? Write down in the chat box. Write down in the chat box what will be the answer for this particular question. So the patient taken up for the normal vaginal delivery who was in labor, the child had a vertex presentation, but the position is occipito-posterior. The head rotated partially, but went into the deep transverse arrest. So you have 4 pictures in front of you. Picture number A, B, C, and D. So what will be your answer, bache? Write down in the chat box. What will be the answer for this question? Very good. Sir, that is going to be option C, which is a triangular shaped pelvis. That is android pelvis. That is android pelvis. So answer is going to be C. So if I talk about option A, that is going to be a gynecoid. Okay. Option B, that is going to be platyploid. Option C, that is going to be android. Option D, that is going to be anthropoid pelvis. That is going to be anthropoid pelvis. Is that clear? So even if the examiner will mention the image, do answer the question perfectly. Clear to everybody? Yes. Can we move to the next question? Chale. Next question. A woman presents to the OPD with the complaints of amenorrhea for the past 2 years. She has a history of postpartum hemorrhage and a lactation failure. So 2 hints are there. So a lady is coming to you with the complaints of amenorrhea, okay, and she had a history of a postpartum hemorrhage, right? So it's a case of a secondary amenorrhea, right? What is a secondary amenorrhea? When a patient bleeded for 3 months or 3 cycles, when a patient is not bleeding for 3 months or 3 cycles, we call it as a secondary amenorrhea, right? Now, sir, she's complaining of the lactation failure and she's complaining of appearance of vitiligo-like white patches also. What is your probable diagnosis? Simply, now, sir, she had a history of a postpartum hemorrhage and now she's complaining of a lactation failure as well and this appearance of vitiligo-like patches. So what is your likely diagnosis? Write down in the chat box. Very good. Sir, it is going to be the case of a Sheehan syndrome. Very good. This is going to be the case of a Sheehan syndrome. Why? Because she had a history of postpartum hemorrhage and followed by that, the complication of excessive bleeding when there is a frequent significant blood loss. What happens? There will be less blood supply to the pituitary as well. There will be ischemia, followed by ischemia, there will be necrosis. And when there is a pituitary necrosis, the classical syndrome is a Sheehan syndrome, right? And all the features, what will be the clinical features of this particular condition? जो कुछ भी pituitary से आ रहा है, FSH and LH, your prolactin, your antidiuretic hormone, your all the other hormones, features will be related to that. What will be the features? Secondary amenorrhea, prolactin is not there, there will be a lactation failure, right? There will be a diabetes insipidus, there will be hypogonadism. These are all the features for the Sheehan syndrome. Now, if I talk about this other syndrome, Stein-Leventhal syndrome, this is another name for the PCOS, or what you call polyendocrine metabolic ovarian syndrome. Okay, Asherman syndrome, sir, Asherman syndrome question will come with a classical history of an abortion or a myomectomy or a secondary postpartum hemorrhage, because all these conditions we go for a curettage. All these conditions we go for the curettage. And when you do the excessive curettage, over the uterus, there will be a scar formation, and that scar formation will predispose to the formation of the adhesions, and those adhesions we call synechiae formations. That's why this syndrome also is called uterine synechiae. It is also called as uterine synechiae formations. Clear? So what are there? There are only adhesions present over there, due to which a patient also have an amenorrhea. So there is nothing wrong about hormones. So if a question mentions even after estrogen and progesterone there was no bleeding seen, think of an Asherman syndrome, because the treatment for Asherman syndrome is going to be very good. Write down in the chat box. So if adhesions are there, I will go with hysteroscopic adhesiolysis. क्या करेंगे? I'll go with hysteroscopic adhesiolysis. So whenever the history of a myomectomy, abortion, okay, or the secondary postpartum hemorrhage. Why secondary postpartum hemorrhage? Because there are chances of retained placental bits over there, and if the volume is too much for these retained bits, we go for the curettage as well, which can predispose to the Asherman syndrome. Then Swyer syndrome we'll discuss. It's 46XY. There is no myth Mullerian inhibitory factor, due to which they developed female genital structures. Okay, now that's all about the Sheehan syndrome. Now if we define the Sheehan syndrome, mention it. So it is due to the, first of all, it is also called as postpartum. This is also called as postpartum pituitary necrosis, or it is also called as postpartum pituitary infarction, because there is a decreased blood supply. Okay, now what is the reason for this Sheehan syndrome? So it occurs when pituitary gland is damaged. Due to significant blood loss. Number first thing. Followed by that, it is also called as, in options they can also mention postpartum hypopituitarism. Clear? Now what are the clinical features? If the question mentions what is the earliest feature of the Sheehan syndrome, your answer should be lactation failure. So I'll mention here the earliest feature is going to be lactation failure. Okay, now what will be the other features these patients have? So we have secondary amenorrhea, because there is no FSH and LH. Secondary amenorrhea, followed by that diabetes insipidus. Okay, followed by that there will be hypogonadism as well. All the features, because all the hormones that are coming from anterior pituitary will be decreased. So what is going to be the treatment, bache? So treatment is simply we substitute the hormones. Substitute the hormones. Okay, and on the MRI we have a classical sign. What is that sign called as? That is called as pituitary ring sign. We call that sign as a pituitary ring sign. Clear? Now let's move to the next question. A 35-year-old lady, gravida 3, parao-livo abortion 2. So she had 2 abortions and now third time she's pregnant. So she's gravida 3 and previous 2 abortions. She's coming to you with a 16 weeks pregnancy. And followed by that there is pain abdomen as well. Now USG bedside was done, which showed there's a funneling of the cervix and the cervical length is 21 mm. What will be the best management for her? So what is your classical diagnosis, bache? Very good. So whenever the cervical length is less than 2.5 centimeter or less than 25 mm, this is a short cervix, or we call it as incompetent os. Incompetent os or short cervix or cervical insufficiency Clear? Now, sir, this short cervix or cervical insufficiency, it can lead to the abortion. And which trimester abortion it will be associated? So it can be associated with a second trimester abortion, because this is related to the anatomy, and anatomical causes are more related to the second trimester abortion. So what will be the management for incompetent os or short cervix? So what happens, this cervix, when it is short, usually cervix is around 4 to 5 centimeter, but if it is less than 2.5 centimeter, bache, what will happen, sir? There will be a painless dilatation of the cervix. Now this patient will have a painless dilatation, due to which there will be a prolapse of membranes, and followed by that there will be the expulsion of the fetus. Got it? Once there is an expulsion of the fetus around 16 weeks, 13 weeks, 18 weeks, 20 weeks, what will happen? So it will predispose to the abortion. Okay, or either if this cervix will have a painless dilatation around 32 to 34 weeks of pregnancy, it will predispose to the preterm labor as well. So what will be the treatment? You will put the band or the cerclage over here, which is called as a McDonald cerclage. So what is the most common cerclage we use? The cerclage on the cervix, which is called as a McDonald cerclage. Okay, now above that, if we put a cerclage, that is going to be a Schrodkar cerclage, or above to that we have a trans-abdominal cerclage. Clear to everybody? So what is the treatment for this particular, what is the answer for this particular question? Very good. Write down in the chat box. So this is going to be the McDonald stitch. This is going to be the McDonald stitch, or we can write McDonald cerclage. We use the muslin tape as well. Okay, now let's discuss about this. First of all, what will be the presentation of this particular question, or what will be the presentation? So whenever we talk about the presentation of this question, how exactly they will frame a question when the cervical length is short? There is a painless dilatation. There is a painless dilatation of cervix. There is a painless dilatation of the cervix. Followed by that, there will be prolapse of membranes. Prolapse of membranes followed by expulsion of fetus. Followed by expulsion of fetus. So this short cervix, it will be also mentioned, it predisposed to preterm labor and abortion. So female will have the history of abortion as well in a clinical case. Followed by that, what will be the treatment? So treatment is going to be the cerclage, and this cerclage is applied. We apply this cerclage around 12 weeks and removed around 37 weeks. So we apply this around 12 weeks and we remove it around 37 weeks. That is going to be the treatment for a short cervix. So remember, the short cervix will predispose to the preterm labor and abortion, and you will only say it's a short cervix when the cervical length is less than 25 mm or less than 2.5 centimeter. Okay, now the answer for this, it's McDonald stitch or McDonald cerclage. Now next question, if the division of the inner cell mass takes place after 8th day of fertilization, it results in the formation of. Now we have discussed in our main sessions about the monozygotic twins and the dizygotic twins, right? Now we know that the fate of the monozygotic twins can be either it can be dichorionic diamnionic, it can be monochorionic diamnionic, it can be monochorionic monoamniotic, or it can be a conjoined twins. While as the fate of the dizygotic twins is, so we have monozygotic twins and we have a dizygotic twins. Monozygotic twins, it can be monochorionic monoamniotic, it can be monochorionic diamniotic, it can be dichorionic diamniotic, or it can be a conjoined twins. right? And here in dizygotic twins, there is only one fate, that is going to be a dichorionic diamniotic. That is going to be a dichorionic and diamniotic. Now the question says that this fate of the monozygotic twins, it depends upon the day of the cleavage. Now it says that the division of inner cell mass takes place after day 8th, bache. So it's not exactly the 8th day he's asking. They are mentioning after the 8th. So if you remember the numbering, after 8, what comes? It is 9. So on day 9, what exactly will be the type of the twin? Very good, sir. On day 9, it is going to be the Momo. It is going to be the Momo. So for day 1 to day 3, we have a dichorionic diamniotic twins, DD. Okay, from day 4 to 8, it is going to be Modi, monochorionic diamniotic. On day 9 to day 13, it is going to be Momo, monochorionic monoamniotic. And then after 13 day, it is going to be a conjoined twins. It is going to be the conjoined twins. Okay, now which of the following is going to be a best type of twins? Write down in the chat box. Which of the following is going to be the best type of twins? Monozygotic or dizygotic twins? Obviously, sir, dizygotic twins, when there is a dichorionic diamniotic. Why? Because less complications. Less complication, because monozygotic twins have more complications, like twin transfusion syndrome. Kya hota hai? We have the complication like twin transfusion syndrome. Okay, that is one baby will be donor and other will be a recipient. Jo donor hoga, he will have less amniotic fluid, that will be oligohydramnios. Jo recipient hoga, he will receive more, he will be a polyhydramnios. Donor will have a less blood, he will be anemic, and recipient more polycythemic. Donor IUGR, recipient, he will be a big healthy baby, large baby, right? So that is why we call it as a poly sequence as well. We call this as a poly sequence as well. Can anyone in the chat box tell me what is the main reason for that twin transfusion syndrome? Because of the AV anastomosis. Because of the AV anastomosis. Okay, and what will be the treatment? So we go for the laser ablation of that. We do a laser ablation for that. Clear? So remember the treatment and the reason for this twin transfusion syndrome as well. This can be the question asked from the twin pregnancy. Now here the simple question was day of cleavage was after 8th day. It was, that means it is a 9th day, which is monochorionic monoamniotic twins, which is monochorionic and monoamniotic twins. Now if we talk about the chorionicity scan of these patients of this type of twins, we have a classical 2 sign. One sign that is going to be a twin peak sign or the lambda sign. Another one is going to be a T sign. Okay, now if you see here, this twin peak sign or the lambda sign, this lambda sign is seen with a dichorionic diamniotic pregnancy. So if dichorionic diamniotic type of twins, we have a classical chorionicity scan sign, that is going to be a twin peak sign or the lambda sign. Okay, now if this T sign is mentioned, so T sign is going to be associated with the MODY, monochorionic diamniotic. Okay, and the most common type of the monozygotic twins we have, that is going to be the MODY. Okay, that is going to be the MODY. And the best type, okay, the best type is dichorionic diamniotic. Why? Because there will be no complications. And with monozygotic twins, what is the complications? Twin transfusion syndrome. Okay, it is due to the AV anastomosis. And treatment for that, we do the laser ablation. Clear? So that is all about the twin pregnancy. Okay, and twin history will be given because the risk factors for this twin pregnancy, it is usually the IVF or the patients who are on the treatment for the fertility on the drugs like clomiphene citrate, letrozole and all. So the question can mention such history as well. Let's move to the next question, guys. A 25-year-old girl was brought by her mother to the clinic with the complaints of irregular periods and acne. A USG scan was performed which showed the following finding. Which of the following is most likely diagnosis? Yes, which of the following is going to be the most likely diagnosis? Very good. Nothing to think much about. So it is going to be a PCOS which is now known as polyendocrine metabolic ovarian syndrome. Polyendocrine metabolic ovarian syndrome. Okay, now what are the classical features? So irregular cycles. Okay, followed by that, patient also complained of acne as well. And the USG, we had a classical sign. This sign is called as pearl of string or ring of pearl appearance. Ring of pearl appearance. Ring of pearl appearance. Now this ring of pearl appearance, it's seen in the PMOS. This is seen with the polyendocrine metabolic ovarian syndrome. Now if these follicles in the ovaries, if they are in the center and they are big, and the question comes with the history of IVF, then your diagnosis is going to be the ovarian hyperstimulation syndrome. Are you getting my point? OHSS. So that will be discussing in the next topic. So remember, this is PMOS. Now if we talk about this PMOS, polyendocrine metabolic ovarian syndrome, this is also called as Steen-Leventhal syndrome. This is also called as Steen-Leventhal syndrome. And this PMOS, it is going to be the most common endocrine disorder. This is going to be the most common endocrine disorder in reproductive age group or in reproductive women. This is going to be the most common reproductive disorder, and this is going to be most common endocrine disorder in a reproductive age group. Now if we talk about the main reason for this PMOS, it is simply due to the insulin resistance. Okay, what is the main reason? So main reason, it is insulin resistance, and due to this insulin resistance, what exactly will happen? So the follicles will not grow. There will be abnormal folliculogenesis and androgens level will be high. Now due to this abnormal folliculogenesis, there will be an ovulation, followed by that, due to the hyperandrogenism, there's going to be acne and hirsutism. Okay, so these acne, hirsutism, amenorrhea, infertility, these are all the features of a PMOS. And what is the reason for this insulin resistance? Sedentary lifestyle, obesity, and other genetic factors as well. Now if we talk about the criteria that is seen in the PMOS, that is called as the Rotterdam criteria. What exactly is the criteria? Rotterdam criteria. And we have three things to remember. First of all, there will be hyperandrogenism. Followed by that, we have an ovulation. Followed by that, so plus minus look on USG. On USG. And on USG, the volume of the ovaries should be, more than 10 cc, and there should be more than 12 follicles. There should be more than 12 follicles. Clear to everybody? This is a criteria which is called as a Rotterdam criteria. Now, sir, in the normal ladies, the bleeding is due to the endometrium that sheds due to the withdrawal bleeding. That is because of the progesterone. So shedding of the endometrium in normal females, it is due to the progesterone withdrawal. But in PCOS, it is ischemic withdrawal. It is ischemic withdrawal because after 14 days, when there is no ovulation, this endometrium creates proliferative at one time. There is a ischemic withdrawal because of this hyperestrogenic state that is seen. Clear to that? And the ovaries, they are 2 to 6 mm large. They are 2 to 6 mm large than the normal, and stroma is 10 to 12 mm thicker. And the stroma is 10 to 12 mm thicker. And due to the increased androgens, these patients have hirsutism and acne. That's why for the treatment we give anti-androgens. Now, due to the insulin resistance, as discussed, there is abnormal folliculogenesis, there is less glucose in the ovary, there's a less energy, and follicles do not grow. Follicles do not grow. And we have these cutaneous marks of the insulin resistance over the nape of the neck, okay, and that is called as, which is called as acanthosis. You can see here in the picture, it is called as acanthosis nigricans. This is also associated with obesity as well. And if the cancer that are associated with this, that is a small cell carcinoma, and we have a gastric carcinoma. Okay, now the appearance, the cutaneous marks of the insulin resistance, what exactly is this? Acanthosis nigricans. We have this black velvety skin over the nape of neck, that is going to be AN. Now next to that, so the appearance of UFG, we have ring of pearl appearance. We have ring of pearl appearance. We have ring of pearl appearance. Clear? Now next to that, sir, we have a Hyran syndrome association. What is HA? Where HA stands for a hyperandrogenism. Where HA stands for the hyperandrogenism. We have IR, that is insulin resistance. IR, that is insulin resistance. And next one, we have AN, which is acanthosis nigricans. Which is acanthosis nigricans. Clear to that? Now, long-term complication of this is going to be a metabolic syndrome, or we also call it as syndrome X, or metabolic syndrome X, or metabolic syndrome X. Now we have these 5 components in the metabolic syndrome or metabolic syndrome X, and out of 3 or more will be confirmatory of this syndrome. Now the triglycerides should be how much? Triglycerides should be more than 150 per deciliter. If we talk about HDL, good cholesterol, it should be less than 50 per deciliter. If we talk about blood pressure, it should be more than 130 by 85 mmHg. Fasting blood glucose should be more than 110, and waist should be more than 35 centimeters or 88 inches. That is going to be the components for a metabolic syndrome. There are going to be components for the metabolic syndrome. Now, can you tell me that, guys, what will be the first line management of these patients? Write down in the chat box what will be the first line if the clinical case is given and they are mentioning that what is going to be the first line management of the PMOS or first line management of the PCOS. What will be the first line management? So mostly in the endocrine disorder, the first line management always is the lifestyle modification. And it is seen that 30% of females had a normal ovulation post lifestyle modification. So always remember, an ovulation treatment, the first is going to be, first you can mark, sir, diet modification. Diet modification, okay, or followed by that you can write or weight loss. Weight loss, okay. Then what can be the other drugs, Kim? So we can give clomiphene citrate, we can give clomiphene citrate. We can start with the first line drugs for the anovulation, and it is also a drug of choice for anovulation in PMOS. That is going to be a letrozole, which is an aromatase inhibitor. And as there is an insulin resistance, we can also go with a metformin. We can also go with a metformin. We can also go with the metformin. Clear? Now, next to that, what will be the treatment for the hirsutism? As hirsutism, it is due to the hyperandrogenism. So we can go with anti-androgens. We can go with anti-androgens. Followed by that, so we can also use spironolactone, L-lactone 5 mg. We can also use OCPs, and we can, for acne, we can use cyproterone acetate. Acetate. Clear? And next to that, we had also surgical treatment. we go with a laparoscopic ovarian drilling. Laparoscopic ovarian drilling. And due to this laparoscopic ovarian drilling, the main goal was to decrease the thickness of the stroma so that ovaries or follicles will grow. So it used to decrease the thickness of stroma. Decrease the thickness of stroma. So that was all about PMOS, polyendocrine metabolic ovarian syndrome. Clear? Now let's go to the next question. A pregnant female presented to the emergency with the complaints of abdominal pain and a vaginal bleeding. Okay, with the complaints of abdominal pain and vaginal bleeding. On examination, the cervical os was closed. There is no prolapse of the products. The fundal height was corresponding to the gestational age. And what is the most likely diagnosis, bache? Now, first of all, a lady is coming to you with the pain abdomen and vaginal bleeding. There is no prolapse of the products, nothing is coming out. Okay, the os was closed on the examination, and when you see the fundal height, it is corresponding to the period of gestation, or height of the uterus is corresponding to the period of amenorrhea. So the classical hints that have been given to this question, that is going to be which type of abortion in the chat box. Very good. Yes, right, it is going to be a threatened abortion. It is going to be the threatened abortion. Okay, now if I talk about the two findings, whenever the patient is coming with the such complaints and you are suspecting that this is the abortion, what will be the findings mentioned? Sir, in incomplete abortion, remember guys, I means open, so os is open. Complete abortion, os is closed. Threatened abortion, os is closed. Inevitable abortion, os is open. That is going to be the os findings. Next to that, what will be the other findings? Sir, in incomplete abortion, fundal height will be less or equal to the period of gestation. In complete abortion, fundal height will be less than the period of gestation, or there will be a normal size, normal uterine size. Sir, why the size of the uterus can be normal? Because whatever was inside in the complete abortion, it is already out. Now the os is closed because there is fully prolapse of the products. Now what has to be done next in this type of abortion is you go for the USG TVS in order to see, or in order to rule out the retained products of conception. Okay, na, RPOC. Now threatened abortion, os is closed. The fundal height is equal to the period of gestation because there is no prolapse for products. And in inevitable abortion, fundal height will be less than or equal to period of gestation. Will be less than or equal to period of gestation. Okay, so that is all about the abdominal findings. Okay, now whenever the question mentions such findings, think of an abortion and rule out what type of an abortion is that. Clear? So I means open, that means inevitable and incomplete, os will be open. And also in septic abortion, os is open, but main 5 you have to remember. That's going to be missed abortion, complete, incomplete, threatened, and inevitable abortion. Now, if we try to define the abortion first, so what is abortion? Abortion means, as per the WHO definition, pregnancy loss less than 20 weeks, or weight of the fetus, more than 500 grams, or the weight of the fetus more than 500 grams. Weight of the fetus more than 500 grams. Now next to that, sir, if more than 20 weeks or more than 500 grams, we call it as intrauterine fetal demise or stillbirth. That is the WHO definition. Clear? Now in the first trimester, the most common cause is going to be a chromosomal. The most common cause, it's going to be the chromosomal. And in the second trimester, the most common cause usually anatomical cause. The cause usually is anatomical cause, something related to the anatomy. Now, if you remember from your anatomy, all the female genital structures, they are coming from the which duct? Very good. They are coming from the Mullerian duct. कहाँ से आता है? They are coming from the Mullerian duct. Okay. Now, sir, if I talk about the anatomical causes and the most common Mullerian duct defect that we have, whenever there is an abnormal fusion, so we have a septate uterus. So what can be the reason for the second trimester abortion? We'll have a septate uterus, followed by that bicornate uterus, followed by that, or we can have incompetent os or the short cervix. That's what we have already discussed in the beginning. Now the septate uterus, sir, there is a septa in between in the septate uterus. So what we exactly do for the treatment? We go hysteroscopically and resect the septa, and the treatment is hysteroscopic resection. So remember about this. First of all, the septate uterus, it is going to be the most common Mullerian defect. It is going to be the most common Mullerian defect. It is going to be the most common cause for second trimester recurrent pregnancy loss. What is recurrent pregnancy loss? When we have two consecutive or more than two abortions, and the second trimester most common anatomical cause, that is going to be septate uterus. And also remember the treatment for this particular condition when a patient is having a septate uterus, that is going to be hysteroscopic resection. That is going to be the hysteroscopic resection. Clear to everybody? That is going to be the hysteroscopic resection. Clear? Now next to that is a bicornate uterus. Next to that, it is going to be the bicornate uterus. Now what is bicornate uterus? So we have two horns, and then it will also predispose to the second trimester abortion. And what will be the treatment for that? So we go for a unification surgery, which is also called as Stressman metroplasty. So what is the management? Management is going to be unification surgery or Stressman metroplasty. Stressman metroplasty, unification surgery. If there is a recurrent pregnancy loss, that's how we treat the bicornate uterus. We unify these two horns. Now what is incompetent os or short cervix? We already discussed when the cervix is short, less than 2.5 centimeters or less than 25 mm. So what exactly we do? So we go presentation of these patients have a painless dilatation, followed by which there is a prolapse of membranes and expulsion of the fetus. So we put the cerclage at 12 weeks and remove at 37 weeks in order to stop the painless dilatation of the cervix. And so management for this is going to be cerclage, and the most common is McDonald cerclage. The most common, it's going to be the McDonald cerclage. The most common, that is going to be a McDonald cerclage. So that was all about the anatomical cause and the management of this. Now the presentation of the abortion, the patient always complain of what? Pain, abdomen. Patient always complain of pain, abdomen and bleeding per vaginal. These patients always complain of pain, abdomen and bleeding per vaginal. Now we have different types of abortion. Number first one, we have a threatened abortion. Then we have inevitable, incomplete, complete, missed and septic abortion. Now talking about the first one, threatened abortion, so patient complains of the vaginal bleeding and pain. Uterine size is going to correspond to the gestational age. That means there is no change, neither increase nor decrease. Cervical os will be closed and fetus will be live as well. So what will be the treatment for that? So treatment for the threatened abortion, please remember, it will be bed rest. Along with that, we give progesterone so that the uterus will be relaxed. So bed rest plus progesterone. Okay. Then followed by that, in inevitable abortion, a patient will come with the pain, abdomen, bleeding per vaginal. On examination, you will see os is open, with a palpable concepts. That means when you do the per vaginal examination, you will see that products are bulging, products are hanging, or the process is going on, right? And uterine size, it can be either same or the smaller. That's what I have mentioned already. And so what will be the management? You go for DNC. Okay, earlier mein agar hai, you can mark suction and evacuation, but usually 80-90% we go with the dilatation and curatac, because suction and evacuation you can only go up to 10 to 12 weeks. Next is incomplete abortion. Incomplete abortion mein patient will give the history of expulsion. Patient will say doctor has passed some clots, okay, and there is partially retained products inside, some part is still inside, os is open, height of the uterus will be less than the period of gestation, and what will be the management further? DNC. Okay, so here the vaginal bleeding will be heavy, size is smaller, os is open, and the products of conception are partially retained. They are partially retained. Next to that, if we talk about a complete abortion, so there will be vaginal bleeding trace are absent, because whatever was inside, it is all out. Size will be smaller, os will be closed, and uterine cavity will be empty. What to do further? So you do further TVS to rule out retained products of conception, to rule out retained products of conception. Next to that is a missed abortion. There will be a vaginal bleeding trace or brownish in color. This is a classical type of abortion in which there are no warning sign and symptom. That means there is no bleeding or pain. It will be just a trace, a spotting. Size will be smaller, os will be closed, and it can be either mismanaged or it can be either differential diagnosis of a blighted ovum. Now, what is blighted ovum? It is an embryonic abortion in which there is no embryo. Rest the findings are same, blighted ovum as well as a missed abortion. But the only difference is there is an embryo formed in case of a missed abortion, while as in a blighted ovum, there is no embryo formation. That is why it's an embryonic abortion. Again, the treatment, DNC or medical abortion. Okay? Next to that is a septic abortion. Septic abortion means, sir, there will be a vaginal discharge. Along with that, there will be a feature of sepsis. What will be the features of sepsis? There will be a fever, foul smelling discharge, increased C-reactive protein, increased ESR. All these findings will be there. Size of the uterus will be variable. It may be larger as well due to the infection, okay, and inflammation. Os is open and the products of conception will be retained. There is a presence of a foreign body and there is a free fluid in the pouch of Douglas or the peritoneal cavity. That is all about the types of abortion. Is that clear? So septic is easy to rule out because there will be features of sepsis only, while as in case of a missed abortion, do remember that the classical finding will be mentioned that there is no bleeding, no symptom, there is a crumpled sac inside with no cardiac activity, but embryo is there. It's an embryonic type of an abortion. But while as blighted ovum, this is an embryonic type of abortion. Next to that, sir, when we talk about the recurrent abortions in the first trimester, this can be the question asked. It's a repeated question in NEET PG as well. In case of a recurrent abortion, what were the recurrent abortions? 2 or more than 2 consecutive abortion. Before it was 3, but a new definition is 2 or more than 2 recurrent abortions. Now, in the first trimester of recurrent pregnancy loss, in the first trimester, the most common cause is an APLA. The most common cause is APLA. What is APLA? It's going to be anti-phospholipid antibody syndrome. It is going to be anti-phospholipid antibody syndrome. Okay. Now let's discuss what exactly is this APLA. Now, if we talk about the thrombophilias, we have 2 types. One is going to be inherited thrombophilia. Next one is going to be a acquired thrombophilia. Now, what can be the reasons for inherited thrombophilias? First of all, so we can have a factor 5 laden mutation. There can be a factor 5 laden mutation. Number second, there can be a deficiency of a natural anticoagulants in our body, that is protein C and protein S. Because what is thrombophilia? Ability to form a thrombus. So whenever these things will happen, the clot formation chances are more. And once there is a formation of these clots, what will happen? The transport between the placenta and the baby, it will be decreased. There will be a placental insufficiency, right? And eventually, once there is a placental insufficiency, it will eventually lead to the abortion because of this clot over there, which is not transporting all the system, all the things to the baby. Now, what will be the reasons for this placental insufficiency? That can be inherited thrombophilia as well, which is due to the factor 5 laden mutation or protein C and S deficiency, protein C and protein S deficiency, and we have prothrombin gene mutation, and we have prothrombin gene mutation. Clear? Now next to that we have an acquired thrombophilias. What are acquired thrombophilias? So we have a classical syndrome which is called as anti-phospholipid antibody syndrome. So we have these three antibodies. What are these three antibodies? Please do remember this, because question can be asked and these antibodies will be mentioned in your case. Now what are the antibodies? We have lupus anticoagulant, number second we have beta 2 glycoprotein, we have anti-beta 2 glycoprotein, and we have the anti-cardiolipin antibody. We have anti-cardiolipin antibody. Now what will be the treatment for these conditions? So we have to prevent the clot formation. So हम क्या देंगे? Low molecular weight heparin plus aspirin. And this has been the question asked, that the lab investigation revealed there was a presence of anti-beta 2 glycoprotein. What will be your management? Answer is going to be low molecular weight heparin plus aspirin. Low molecular weight heparin plus aspirin. So what is APLA? It is anti-phospholipid antibody syndrome. Remember these three antibodies. Next to that, if we talk about medical termination of the pregnancy, so single doctor opinion is needed up to 20 weeks. Sir, if two doctor opinion is needed, then it is between 20 to 24 weeks. We need two doctor opinion. As per the MTP amendment 2021, MTP can be done up to 24 weeks. It can be done up to 24 weeks, bache. But remember, in case the classical clinical case is given and they have mentioned that there was a failure of the contraception or failure of the IUCD and still this patient is pregnant. So in case of contraceptive failure, you can go up to only 20 weeks. You can go up to 20 weeks, but if there is any congenital anomaly, there is no limit. Okay, but there should be a medical team present, one radiologist, one pediatrician, one gynecologist, and one member from the board. So that is all about the MTP Act. Now sir, if we talk about the drugs for medical abortion, now for the weeks, if we divide as per the weeks, due to the medical abortion can be done with the drugs up to 7 weeks as per the government of India, and the WHO says you can go up to 9 weeks, right? And then after 9 to 12 weeks, you can go with the suction and evacuation. Followed by that, after 12 weeks, you have to go with a prostaglandins. You have to go with the prostaglandins. Now the question has been asked that the drugs for the medical abortion, as we know, we use the two drugs, mifepristone and the misoprostol. Mifepristone is going to be antiprogestin, which will kill the fetus, and misoprostol is a prostaglandin, which will expel this fetus out. Okay, now the question has been asked, what exactly will be the correct dosage for the mifepristone and the misoprostol? What will be your answer? Yes, very good. So it's going to be mifepristone 200 mg and misoprostol 800 micrograms after 48 hours. Option C is the correct answer. Option C is the correct answer. So first we give 200 mg of mifepristone, followed by that we give 800 micrograms of the misoprostol. Okay, now remember that first of all, government of India says we can go up to 7 weeks, and WHO says you can go up to 9 weeks. Remember this information. This is for the medical abortion. Then up to 12 weeks, you can go for suction and evacuation. Post medical termination, suction and evacuation. More than 12 weeks onwards, prostaglandins are the choice. prostaglandins are the choice. Okay, now talking about the drugs, we give the mifepristone and the misoprostol. We give the mifepristone, you have to give 200 mg. Followed by that, we give a misoprostol. It is a prostaglandin. It will expel the fetus out. That is 800 micrograms. If the pregnancy is less than 7 weeks, you can give also 400 micrograms. But if a question mentions, you mark 800 micrograms. Then on day 15, do USG to ensure process is complete, or to rule out retained products of conception. Okay, so this is going to be day 1, that's going to be day 3, and on day 15 you will do USG. Which USG? Don't mark TAS, it is TVS. You will do TVS in order to rule out the RPOC, retained products of conception. So that was all about the medical abortion drugs. Okay, now next to that, a 30-year-old primee attends the antenatal clinic at a period of amenorrhea of 35 weeks. So lady is coming to the antenatal clinic, period of amenorrhea 35 weeks. She has a single fetus in the breech presentation. That means buttocks are lying in the lower segment. The ultrasound scan confirms the presentation. There is no other abnormalities detected. What is the next step in the management of normal vaginal delivery? So the question is saying that a lady is coming to you and this is a confirmatory case of a breech presentation, and it has been confirmed by the scan. It has been confirmed by the scan. Now she has a single fetus in the breech presentation, and now what will be our next step in the management of the normal vaginal delivery? Now you know that breech presentation, we have a different types of presentation. So first of all, what exactly is a presentation? So presentation simply means which part of the fetus is lying in the lower segment, or the pole of the fetus lying in the lower uterine segment. Now if head is there, we call it as a cephalic presentation. If buttocks are there, we call it as a breech presentation. If shoulder is there, we call it as a shoulder presentation or a transverse presentation. Now if we have to deliver this baby by NVD, what can we do? So write down in the chat box, everyone. Let's understand first. Presentation, very good. Some of you are right. You have answered option C. Yes, we have to perform an external cephalic version at 36 weeks. How many weeks? At 36 weeks. Now, what exactly is this external cephalic version or external cephalic version, and when to perform, when not to perform? Let's understand this. So first of all, what is presentation? So presentation simply means pole of the fetus. It simply means pole of the fetus lying on the lower segment. Pole of the fetus lying on the lower segment. Now we have three types. Cephalic, it means head is at the lower segment. It means head is at lower segment. Number second, we have shoulder presentation. It means shoulder is at lower segment. Next to that, we have breech presentation. Breech is at lower segment. Lower segment, right? Now this shoulder presentation, it's also called as transverse presentation. It's also called as transverse presentation. Now if cephalic and breech is coming with a vertical lie, we deliver via NVD, vertical lie. If it is a transverse, we go for a cesarean section. But sir, this transverse lie, whenever it's coming, it's not always we go for a cesarean section. It depends upon the weeks, right? So we have three scenarios. Now, whenever the breech and shoulder presentation comes with a transverse lie, remember, sir, if the lie comes at 37 weeks, if the transverse lie will come at 37 weeks and the patient is in labor, your answer should be cesarean section. If the same patient comes at 37 weeks and not in labor, your answer should go with external cephalic version. Your answer should go with external cephalic version. Now, what exactly is external cephalic version? Externally, you rotate the baby, and from transverse line, you make it as a vertical line, and then you deliver through normal vaginal delivery. Now, for this external cephalic version, make sure that it is done after 36 weeks onwards or at 36 weeks. Why? Because the amniotic fluid levels are decreased after 32 to 34 weeks. So amniotic fluid levels are like this. At 30 weeks, they are raising. At 32 to 34 weeks, they are at the peak. And followed by 34 weeks, they will start decreasing. And around 40 weeks, it's almost only 600 ml. Now, sir, if I try to do this external cephalic version around 32 to 34 weeks, the baby will change its position again. So whenever this clinical case will come, and if it mentions that the female is in the labor at 37 weeks or at term pregnancy, your answer should be a cesarean section. If it mentions that at 37 weeks she is not in the labor, but she is a case of a transverse presentation, so you mark the answer as external cephalic version. You mark the answer as an external cephalic version. External cephalic version. And if she comes around at 32 to 34 weeks, so what you will write? So wait and watch. Wait till 37 weeks. Okay, wait till 37 weeks. So at 37 weeks, the levels are decreased, so you can go for external cephalic version. So external cephalic version not done around 30 to 32 weeks. So not done. Why? Because amniotic fluid keeps increasing and baby will change position, so that's all about the transverse line. Now we have a breech presentation as well. We have different types of breech. We have a frank breech, the most common. We have a complete breech, which is a flex breech, or the footling breech, which is an incomplete breech. Now if we talk about flex or complete breech, we can go for a normal delivery. It can be delivered through a normal vaginal delivery. If I talk about an extended or a frank breech, that can be also delivered normally, normal vaginal delivery. But in case of a footling or incomplete breech, you have to deliver through cesarean section. Clear? Now, sir, the breech delivery, best type of the breech for the normal delivery, that is going to be a frank breech. Which is also a most common one. Followed by that, in breech presentation, we go for the breech assisted delivery. So we perform some maneuvers, and for the extended legs, it's a NEET PG recall question. So this is going to be a breech part, buttock part. It is touching the lower segment. And if you see that we deliver the legs with a maneuver, these extended legs are delivered with the maneuver, which is called as a Pinard's maneuver. What is the maneuver called for extended legs? So the maneuver is called as Pinard's maneuver. For extended arms, we have a maneuver. So remember that when you love someone, you hug them with your arms. So love sets maneuver for the arms. So what is the maneuver for extended arms? It's going to be a love sets maneuver. Now after coming head, we have a maneuver, which is called as jaw flexion and shoulder traction. It is also known as Mauritius simile weight maneuver, or it is also called as Mauritius simile weight technique. Maneuver. So this is going to be the Mauritius simile weight maneuver. Now next to that, forceps that we use, the outlet types of forceps that we use, that is going to be a Piper's forceps. That is going to be the Piper's forceps. Okay, and so we have one more technique to deliver the head, which is called as Byrne-Marshall technique or Byrne-Marshall maneuver. So what exactly we do in the Byrne-Marshall maneuver? You see, first of all, we have delivered the legs part with the help of a Pinard's maneuver. We have delivered these arms with the help of a Lausset's maneuver. Now about the head we have to deliver. You let the baby hang for a while until you see the hair over here. Clear? Now once the hair is visible, then you hold his feet, followed by that free his mouth and suck him out and swing his head clear. So this swinging of the baby, let him hang, holding his feet, this is called as a Byrne-Marshall maneuver. Again, this is the previous year question, image based for the NEET PG, and this Pinard's maneuver has been also asked. So breech presentation is going to be most important. So remember, Pinard's maneuver, Lausset's maneuver, and Byrne-Marshall maneuver for the breech presentation. In part 1, we have discussed Johnson's maneuver. That was for the uterine inversion. We have discussed Macrober's maneuver. That was for the shoulder dystocia. Then other maneuvers, Woodcock's screw maneuver, Zavanelli maneuver, and Gaskin's or Folin's maneuver, all for the shoulder dystocia. Clear? Now next to that, now next question, guys. Okay, somebody is asking internal podalic version in the chat box. Internal podalic version, we have always a risk for the uterine rupture. Okay, but we do perform this internal podalic version usually when we have the twins, when the first twin is a cephalic and second is a transverse, because once the first twin is delivered, the uterus is so relaxed that you can perform the internal podalic version. Okay, but the complication always, or the risk of always, is there related to the rupture of the uterus. Clear? Next question to you guys, a multiparous woman in the labor. This is an easy one, guys, because we have just discussed this. The multiparous woman is in labor at 38 weeks of gestation. Okay, on examination, the uterus appears asymmetrical. The fundal height is less than the period of amenorrhea. In fundal grip, remember, in fundal grip, the fetal pole is not palpable. In pelvic grip, the lower pole of the uterus is empty. So if you remember the Leopold's maneuver or the fundal grips or the different types of grip, fundal grip, we have pelvic grip, we have Pavlik grip. Okay, now sir, in the fundal grip, the fetal pole was not palpable, and in the pelvic grip, the lower pole of the uterus is empty. The fetal presentation will be, so what type of the fetal presentation will be seen here? Very good. In the chat box, what will be your answer? So first of all, let's understand what exactly is a fundal grip and what exactly is a pelvic grip and the Pavlik grips. Now if I talk about these different types of grip, we have a fundal grip, which is the first Leopold's maneuver. Then we have a second one, lateral grip. Then we have the Pavliks and we have the pelvics. The fundal, the purpose of this, it determines the fetal pole and the fetal pole occupying the fundus. Now sir, if head is around there, it will be hard, round and palatable. If breech is around there, when you palpate the fundus, you will see that it is soft. It is soft, broad or irregular. So the significance of this first Leopold's maneuver is that it identifies the fetal presentation. It identifies the fetal presentation. Clear? Next one is the second Leopold's lateral grip. So the purpose, one side smooth and firm, fetal back, other side irregular limb. So it can tell me about which part of the fetus is on the posterior side. So it can tell me about the occipito-posterior or anterior, right? Then the Pavliks, it identifies the presenting part. So which part of the fetus is presenting at the lower uterine segment. Okay, if head is, it is hard. If it's hard over there, it is a cephalic presentation. If it is a soft over there, it can be a breech. And if it is empty, that means it's a transverse presentation, which is called as a shoulder presentation. Now pelvic grip, fourth one, the purpose, it assesses the degree of the fetal descent. Now how much fetus is inside the pelvis, and it determines cephalic prominence as well. What is the clinical significance? It evaluates the engagement, that is entering of the head into the pelvis. So these are four grips. Remember the first three grip, the patient, a doctor or an examiner is facing towards the face of the patient, but in the pelvic group, the examiner who is examining the patient is looking towards the feet of the patient. Okay, and one hand, if the image is given, think of a Pavlik's grip. Now in this clinical question, it was mentioned that the pelvic grip, the lower pole of the uterus is empty. Now here you cannot see anything in the lower pole, right? Because so fetal head is not there. And the fundal grip, fetal pole is not palpable, because when it is not palpable, that means there is a transverse presentation. And what type of presentation is that? Transverse, it's going to be a shoulder presentation. It's going to be shoulder presentation, because once the baby is in this transverse lie like this, so this is going to be empty, this is going to be empty. That's what is mentioned. Fundal grip, it is not palpable, and in pelvic grip, lower pole of the fetus is empty. So this is a classical type of which type of presentation? That is going to be a shoulder presentation. And shoulder presentation or the transverse line coming in the labor, cesarean section, not in the labor in term, external cephalic version, coming around 32 to 34 weeks. Wait till 36 weeks and then you perform the external cephalic version. So here answer was what? You perform an external cephalic version at 36 weeks, because currently she is around 35 weeks and she is not in labor. So at 36 weeks, the levels will decrease. That's why I will go with an external cephalic version. So that was all about the different types of grips as well. Clear to everybody? Now next question. A primary gravida is brought home by her relatives just after 1 hour of the vaginal delivery. The baby is healthy and the baby is doing well. On examination, the patient is hypotensive. On examination, the patient is hypotensive, hypoxic, and has disseminated intravascular coagulation. So DIC, or you can call coagulopathy. Which of the following is the most likely diagnosis? Now, my dear students, it's a classical triad of what? Hypotension, hypoxia, and coagulopathy. This is a classical diagnosis of a amniotic fluid embolism. This is a classical diagnosis of an amniotic fluid embolism. As you know, the pregnancy is a hypercoagulable state. So what happens? There is amniotic fluid, and the contents of these amniotic fluids, they enter into the maternal circulation. They enter into the bloodstream, and as pregnancy is a hypercoagulable state, it make an embolus, goes to the maternal circulation, leading to the failure, cardiorespiratory failure, and the coagulopathy. Such an embolism is called as amniotic fluid embolism. As in the main sessions, we have already discussed that whenever the pregnant lady with this amniotic fluid history, with the triad of hypoxia, hypotension, and coagulopathy is coming, think of an amniotic fluid embolism. Whenever classical case of deep venous thrombosis is given, or the history of any pelvic surgeries or a hip surgeries is given, think of a pulmonary embolism. Whenever there is a road accident, road traffic accident history given with the fracture of the long bones, F for fracture, F for fat embolism. Or whenever there is a history of these deep sea divers given, and if there is an entry of the air more than 100 cc, think of an ear embolism. Think of an ear embolism. Okay, so here what is the answer? Very simple, so that is going to be amniotic fluid embolism. Now we have three scenarios also, bache. Now whenever the patient after the delivery goes into the shock, normally goes into the shock, think of a postpartum hemorrhage. Number first very thing, if it is mentioned that patient immediately goes into the shock just after the delivery, think of an uterine inversion. You have discussed in the part 1 what was uterine inversion. So it was simply turning upside down of the uterus, or prolapse of the fundus of the uterus into the cavity. That was a uterine inversion. And if a patient goes into the unexplained shock, that means the patient was fine and baby was fine as well, delivery was very nice, but eventually patient collapsed with hypoxia, hypotension, and coagulopathy, think of an amniotic fluid embolism. You think about amniotic fluid embolism. Amniotic fluid embolism. Is that clear to everybody? Is that clear to everyone? Next, amniotic fluid embolism. Now, what is amniotic fluid embolism? First of all, sir, it simply means there is an intravascular invasion of the maternal circulation by amniotic fluid and its contents, and they further lead to the DIC. So it's defined as intravascular invasion it's defined as intravascular invasion of maternal circulation by amniotic fluid and its contents, leading to DIC. And what is the classical triad we have, which was mentioned earlier? So hypotension, hypoxia, and coagulopathy. Hypotension, hypoxia, and coagulopathy. Clear? So that is all about amniotic fluid embolism. Now the next question, guys. A 12-year-old girl is brought to the OPD by her mother. She's concerned that she is shorter than her peers. On evaluation, which of the following would you expect to find? So think of an Turner syndrome, yes. So ultrasound shows the streak ovaries and small uterus. Echo showed the tricuspid stenosis. No, there is usually a bicuspid aortic valve stenosis, the most common cardiac defect. Ultrasound shows hepatomegaly and altered echostiction. No. Ultrasound shows the single kidney. No. So classical feature of Turner syndrome, we know that we have streak ovaries or streak gonads and small uterus. Okay. Now, sir, what exactly is a Turner syndrome? So it's a most common, first of all, it is 45XO monosomy, and it's the most common cause of primary amenorrhea, that is the first thing, 45XO. Second thing about the Turner syndrome is, sir, there is a short stature, and for the short stature, what is going to be the gene defect? It's a SHOX gene. Third question, PYQ FMGE, that which of the following is incorrect about the Turner syndrome? So there is no mental retardation. The IQ is normal. There is no mental retardation. There is a pubertal failure. That's what we have mentioned. Streak ovaries. There is a broad chest seen, curvature of the spine, widely spaced nipples, low hairline, low set ears, congenital heart disease. What is the most common cardiac defect associated with the Turner syndrome? Your answer should be bicuspid aortic valve stenosis. The most common should be bicuspid aortic valve stenosis. Okay, do not mark coarctation of aorta. Yes, that is also seen, but that is not going to be the most common. Next to that, there is a structural abnormality of the kidneys, okay, and also knee deformity. And these patients, they have increased chances of developing what? Increased chances of developing metabolic syndrome. Increased chances of developing metabolic syndrome. So that's all about the Turner's syndrome. That is all about the Turner's syndrome. So short stature, web neck, streak ovaries, okay, bicuspid aortic valve stenosis, that is going to be Turner's syndrome. Next to that, a 32-year-old female nearing her due date has been admitted following the regular contractions. The resident doctor did an examination and told the intern the head is at the +1 station. Head is at the +1 station. Where is the exact position of the head? So in order to monitor the labor, okay, we check the fetal head station and we take the reference point as ischial spine. So what is a reference point for that? So reference point we take as ischial spine. So why we are taking ischial spine as a reference point? Because it's a narrowest inlet of the pelvis. It's the narrowest inlet of pelvis. Now, my dear students, when the head is at the ischial spine, that is 0. So here it is a ischial spine. So head at the ischial spine is a station 0. Above that, it's going to be -1, -2, -3. Below that, it's going to be +1, +2, +3. So if an image is given like this and the head is at the level +1 station here, so that means that +1 station means here that head is below the ischial spine. So if in question +1 station is mentioned, and where exactly is the position of the head, bache? Where exactly is the position of the head? Sir, it is just below the ischial spine. It is just below the ischial spine, right? Why we are taking ischial spine as a reference point? Because it's the narrowest inlet of the pelvis, right? If it would have been here -1, the answer would have been above the ischial spine. If the option here would have been the 0 station, then the answer would have been at ischial spine. So remember, -5 to 0, the baby is floating above the ischial spine. At 0, baby's head is aligned with the ischial spine. That means at the level of ischial spine. Then below that, baby has descended beyond the ischial spine. That is 0 to 5. Baby has descended beyond the ischial spine. So that is going to be about the station or a head station. Next question, a 28-year-old woman has been on the OCPs for 5 months. She presents to the OPD with 6 weeks of amenorrhea and her UPT is positive. Which is the most accurate method to determine the gestational age in this woman? Now, this lady was on OCP, so that she does not remember her last menstrual period. Now, in order to determine the gestational age in this woman, what exactly is going to be the best accurate method? So we go for a crown rump length on the ultrasound. In the first trimester, the best one is crown rump length. Yes, we also calculate the EDD, but for that we need a last menstrual period. So that we apply the Nagli's formula on that, 9 months plus 7 days, and that can give me an estimated date of delivery. But that Nagli's formula is applied on the females who have the regular cycles, 9 months plus 7 days. Now let's understand it first, sir. Best parameter for the fetal estimation age in the first trimester, that is going to be a crown rump length. That is going to be a crown rump length. Second trimester, it's going to be biparietal diameter. Third trimester, it's going to be a femur length. But overall best is a crown rump length. It's going to be crown rump length. Okay. Now the first thing. Second one is about, sir, what exactly is Nagli's formula? Now if I define this Nagli's formula, so this Nagli's formula, it's used in order to know the estimated date of delivery. So what exactly we do? 9 months plus 7 days. 9 months plus 7 days to LMP. 9 months plus 7 days to LMP. Add to LMP, last menstrual period. But this Nagli's formula, it is for the females have 28 days cycle. This is for the females who have 28 days cycle, regular cycle. Okay. Now, if for example, I'm giving you an example, if a female is having the LMP of the 15th of March. So LMP of 15th of March, what is going to be the EDD? So we go 15 plus 7. Yes, write down in the chat box. So it's going to be April, May, June, July, August, September, October, November, and December. So 15th of December, it's going to be 9 months. Then add on the 7 days, it's going to be 22nd of December EDD. Clear? So example, I make the example here only. LMP of 15th of March. Now, if I do the EDD of this patient, if I try to find the estimated date of delivery of this patient, I will add on 9 months plus 7 days. That is going to be the 22nd of December. That is going to be the 22nd of December. But remember guys, it's only for the females who have the regular cycles. Now sir, what if cycle is long? Then what to do next? Add on extra days. What does that mean? Sir, that means that we will do, if a cycle is 32 days, we'll do 9 months plus 7 days plus 4 days, because 28 se kitne din zyada, that is going to be 4 days. If cycle is short, subtract the days. If it is 25 days, then subtract 9 months plus 7 days minus 3 days. Clear? So that is about a Negley's formula. Now next to that, we have a fundal height depending upon the weeks. So at 12 weeks, the fundal height is at the pubic symphysis. At 12 weeks, it's pubic symphysis. So how do you remember? PUX, PUX, 12, 24, 36. At 12 weeks, pubic symphysis. At 24 weeks, it will be umbilicus, but which border of umbilicus? It will be upper border of umbilicus. It's going to be upper border of umbilicus. Then at 20 weeks, it's going to be lower border of umbilicus. It's going to be lower border of umbilicus. And at 36 weeks, it will be at cephisternum. At cephisternum. At 16 weeks, between the pubic symphysis and the umbilicus. Then at 30 and at 28 and 32 weeks, it will be between the umbilicus and the cephisternum. Clear? Now, followed by that, chorionic villus sampling. When exactly we do this, it is done around 10 to 13 weeks. CVS is done around 10 to 13 weeks. If you do less than 10 weeks, it can lead to the fetal loss, 1% chance, and oromandibular defects. And amniocentesis are done around 16 to 18 weeks. No? Second trimester, right? So chorionic villus sampling done around 10 to 13 weeks. So if you do less than 10 weeks, complication oromandibular defects, and amniocentesis 16 to 18 weeks. Then we have a triple test. What are the parameters of the triple test? So we check beta HCG. Along with that, alpha fetoprotein. Along with that, we have estriol, that is unconjugated E3. And quadruple test, sir, it is going to be triple test. It is going to be triple test. Along with that, we have inhibin A. Along with that, we have inhibin A. So if they ask which of the following parameters is not seen in a quadruple test, so remember they will mention inhibin B. Inhibin A is there, not inhibin B. And inhibin is a marker for which ovarian tumor also? So it's a marker for the granulosa cell tumor. Which inhibin? Inhibin B. B is better. Now next question guys. A 25-year-old female with the history of 2 weeks amenorrhea came in an emergency with the complaints of scanty vaginal bleeding. On examination, no adnexal mass was noted. The lab investigation HCG was 1400 units. On UHG, uterus was bulky. Trilaminar endometrium was seen. Patient vitals are stable. What is the next step to do? Now just 2 weeks amenorrhea. Okay. And emergency, she complains of this scanty vaginal bleeding. There was no adnexal mass noted. Okay. I can say that the investigation so far was inconclusive. So we have already performed this beta HCG. And now what to do next? Sir, I will repeat the beta HCG after 48 hours. I will repeat the beta HCG after how many hours? After 48 hours. You can see this is a trilaminar endometrium. Now, sir, after 48 hours, now a female is coming. If the radiological scans are inconclusive. That means आपने TDS किया, आपने TS किया, and you did not see anything inside the uterus, and you did not see anything inside the tubes as well. Now, what to do next? You go with a beta HCG, because she's just 2 weeks, so you cannot expect. You will see. Now, what to do next? So we have to do beta HCG, and beta HCG was already 1400 international units. Now, sir, I will repeat this beta HCG after 48 hours. Now, there can be 3 scenarios. Agar double हो रहा, it is gonna be an intrauterine pregnancy. If it is taking a time to double, that means from 58 just 70. Okay, the doubling time is prolonged, it is going to be ectopic pregnancy. And if this beta HCG is decreased after 48 hours, it is going to be a abortion. So let's understand the diagnosis of pregnancy with respect to the beta HCG levels. So doubling in 48 hours, it is going to be intrauterine pregnancy. Doubling in 48 hours, it's going to be intrauterine pregnancy. So doubling in 5 to 7 days, it's going to be ectopic pregnancy. It's going to be ectopic pregnancy. Then also, if decreased after 48 hours, if decreased after 48 hours, then it's going to be the case of a abortion. Then it's going to be the case of an abortion. Now also we can check serum progesterone levels. If more than 25, it is going to be the normal intrauterine pregnancy. And if it is less than 25, it is going to be the ectopic pregnancy. It is going to be the ectopic pregnancy. Now we have a double decidual sac on UHG as well. You can see here, this is a double decidual sac. Okay. Now this inner line, in inner layer, it is formed by the decidua capsularis, and outer layer, it is formed by the parietalus. So we have this parietalus and the capsularis to visualize an appearance called as double decidual sac sign. And if this double decidual sac sign is present, this is going to be a intrauterine pregnancy. And if this double decidual sign is absent, this is going to be an ectopic pregnancy. Now, outer layer, double decidual sac sign, outer layer is by decidua parietalus. Decidua parietalus, and the inner layer, it is decidua capsularis. That is decidua capsularis. And what exactly it indicates? Sir, it indicates intrauterine pregnancy. It indicates intrauterine pregnancy. Is that clear? And if you remember in the part 1, I had delivered a question that in which double decidual sac was absent. So if it was absent, that is going to be a ectopic pregnancy, because if pregnancy is inside the uterus, it's a normal pregnancy. Outside the uterus anywhere, it is an ectopic pregnancy. Clear to that? Now next question. A 24-year-old woman who is being treated for infertility with human menopausal gonadotrophin. So she's treated with HMG, and we are giving this stimulation therapy as well. So now she's coming with the complaints of the sudden abdominal pain, nausea, vomiting, and the breathlessness. So she's having the breathlessness followed by that abdominal pain, nausea, vomiting. The finding of the ultrasound is shown below. What is your most likely diagnosis? Everybody in the chat box, what is going to be the most likely diagnosis? So tell me in the chat box. The USG image has been given. Now, she had a treatment for the infertility, and followed by that, she was being treated with HMG, and now suddenly she has a complaint of an abdominal pain, nausea, vomiting, and the breathlessness. The finding of the ultrasound is shown below. What is your likely diagnosis? Very good. It is ovarian hyperstimulation syndrome. So when we give this stimulation therapy injection FSH, in case of an IVF, we call it as controlled stimulation therapy. But if in case it goes excess, it will lead to the complication called as ovarian hyperstimulation syndrome. Okay. Now, what exactly are the classical features of these patients? They have the bloating, abdominal pain, and then nausea, vomiting, okay, and due to the increased capillary leak, they will have ascites as well also associated in the severe conditions, and when this OHSS goes beyond the severity, it can lead to the end organ damage as well. Clear? So in PCOS, there is these follicles, they are smaller and they are over the periphery. PCOS mein, they are over the periphery, ring of pearl. But here they are big and they are in center. They are big and they are in the center. And we call this sign as a, what is the sign? Anybody in the chat box? We call this sign as a spoke wheel sign as well. We call this sign as a spoke wheel or cart wheel sign as well. Clear? Now next to that, always remember, it is characterized by a multiple ovarian follicular cyst accompanied by increased capillary permeability. It happens most often as a complication of ovulation induction therapy for infertility, and it occurs due to the stimulation of VEGF, that is vascular endothelial growth factor. Clear? So what are the features? Nausea, vomiting, bloating, okay, and in severe it will be ascites as well. So treatment will be, you give the IV fluids, and followed by that, if it is too much of ascites, we have to give albumin therapy as well. And severe complication at the end of OHSS is going to be the end organ damage. So risk factor is actually this HMG is the risk factor, but the causative thing is going to be beta HCG for this. So risk factor is what? The HMG. It's coming as a risk factor, but the cause is usually the beta HCG. Now, if we talk about the drug of choice for anovulation, we have clomiphene citrate. Clomiphene citrate. If the drug of choice of anovulation in PCOS has been asked, your drug of choice is going to be letrozole, which is a first line drug and aromatase inhibitor. If there is an anovulation due to the pituitary cause, we give the human menopausal gonadotrophin, HMG. If there is a hypothalamic lesion or hypothalamic cause due to the Kalman syndrome, we will give the pulsatile GnRH. And if there is an anovulation for controlled ovarian stimulation in IVF, we give human menopausal gonadotrophin. That's what we call controlled ovarian stimulation. But if there is hyperovarian stimulation, then it is an OHSS complication. Next to that, sir, after the successful delivery of the baby, the obstetrician witnessed that the episiotomy performed has extended away the backwards beyond the perineal body. Now, which among the following structures is likely to be injured in this case? Which among the following structures is likely to be injured in this case? Now, first question is, sir, why we perform the episiotomy? Okay, what is episiotomy? So, episiotomy is simply the planned incision which is given on the perineum so that the birth canal will be widened, or to facilitate the delivery of the baby. Now, what are the indications? Indications of these episiotomy first of all, sir, if there is an obstructed labor, if we have obstructed labor. Number second, if there is a breech presentation, so we have to perform the episiotomy. Followed by that, if we have shoulder dystocia, that means delay of the delivery of the shoulder more than 1 minute after the delivery of the fetal head, or if there is a macrosomic baby. These are all the indications of the episiotomy. Now we have a different types of episiotomy. We have a mediolateral episiotomy and the midline episiotomy, but the most common that we perform is going to be the mediolateral episiotomy. Why? Because of the less wound extension. Even though midline episiotomy has more of an advantage than mediolateral, but one of the best advantage of a mediolateral over the midline is less wound extension. Okay, and we have these classical scissors. These are called as episiotomy scissors. क्या बोलते हैं scissor को? This is called as episiotomy scissor that we use. It can be image based question asked as well. So these are all the indication of episiotomy. Now, sir, what are the structures resected in the episiotomy? Now let's understand first the full episiotomy and then we go back to the question. Now structures, first of all, we are going to cut the skin. सबसे पहले skin, then followed by that we have subcutaneous tissue. Followed by that we have subcutaneous tissue. Then we have superficial transverse perineal muscles. We have superficial transverse perineal muscles. Followed by that we have deep transverse perineal muscles. Next we have muscle fibers of bulbospongiosus and levator ani. Levator ani. Then we have transverse perineal branch of the pudendal nerve. Pudendal nerve. And the last, posterior vaginal wall. And if you extend backwards than that, what will be injured? External anal sphincter. We have posterior vaginal wall. And in case it extended away backwards beyond the perineal body, the likely structure to be injured is external anal sphincter. External anal sphincter. Is that clear? Now, remember the structures restricted, and the question can be also asked, muscles do not cut during the episiotomy. What you will not cut during the episiotomy is ischio-coccygeus or the coccygeus. We have ischio-cavernosus, anal sphincter, and obturator internus. Remember, these muscles are not cut during the episiotomy. Okay, during the episiotomy. Clear to everybody? Yes. So that's all about it. And recent NEET PG question was asked that structures to be stitched back, what is the sequence for that in an episiotomy? So do remember muscles cut or structures resected and structures which are not resected during the episiotomy. And the most common one is going to be the mediolateral. Why? Because less wound extension. Remember that. And what are the indications? Obstructed labor, breech, shoulder, and macrosomic baby when the baby is more than 4 kgs. Next to that, the next question always that will be in your exams. That's from the vaginitis. A 30-year-old woman presents to your OPD with complaints of a foul-smelling discharge for the past 3 weeks. On examination, the discharge is thin, creamy white, and has a fishy odor on the addition of 10% of KOH. What is the most likely cause? So what will be your answer for this question? What will be your answer for this particular question? So you have a lady coming to you with the complaints of a foul smelling discharge for past 3 weeks. Complaints of foul smelling discharge for past 3 weeks. And on examination, the discharge is thin, creamy white, and has a fishy odor on addition of 10% of KOH. Classical Ansels criteria is defined in the case. So Ansels criteria with the which diagnosis? It is going to be, first of all, the diagnosis is bacterial vaginosis. What is the diagnosis, bache? The diagnosis is bacterial vaginosis. Okay, and the causative agent for the bacterial vaginosis is Gardnerella. What is the causative agent? It's going to be a Gardnerella. Now let's talk about different types of vaginitis. The first one that we are going to discuss is a candidiasis. First of all, we are going to discuss is a candidiasis. Now about the candidiasis, remember, so it's caused by Candida albicans, and the pH is acidic pH. The pH is acidic pH. And the Candida albicans, it's a fungi. It's a dimorphic fungi. Next to that, sir, in candidiasis, mycelia is responsible for invasion. It is mycelia which is responsible for invasion and the adherence of this candida into the vaginal epithelium. Next to that, the type of the discharge we have is a curdy white discharge or cottage cheese like discharge, and mostly caused by, as said earlier, candida albicans. Candida albicans. Now followed by that, so the treatment local cream, we have clotrimazole, and orally we give fluconazole. Orally we give is fluconazole. Next to that is a trichomoniasis. Now trichomoniasis, sir, the pH is alkaline pH. The pH is alkaline pH, and it's caused by Trichomonas vaginalis. It's caused by Trichomonas vaginalis. Now next to that, the type of the discharge that is seen in case of trichomoniasis, it's frothy or greenish discharge. It's going to be frothy or greenish discharge. And due to the severe inflammation, we have a strawberry vagina. Due to the severe inflammation and excessive pruritus, we have a strawberry vagina seen, and which is also called as colpitis macularis. क्या बोलते हो? Colpitis macularis. Drug of choice is metronidazole. Drug of choice is metronidazole, and this has been the question asked. Remember, the partner is also treated. Partner is treated as well. Partner is treated as well. That is all about the trichomoniasis. We do see the clue cells in case of a trichomoniasis level, but they are not specific. They are not specific. Next one of the most important one, that is going to be a bacterial vaginosis. That is going to be the bacterial vaginosis. Now about the bacterial vaginosis, first of all, sir, it's a most common type of a vaginitis. It's the most common type of vaginitis. Followed by that, it's caused by Gardnerella, and the pH is alkaline pH. The pH is alkaline pH, and it's caused by Gardnerella. Now about the bacterial vaginosis, we have a classical criteria, and out of 4, 3 or more than 3 should be present. Out of 4, 3 or more than 3 need for the diagnosis. So what are the 4 things that are included in the answers criteria? Number first very thing, that is going to be a clue cells. Number first one, that is going to be the clue cells. Number second, that is going to be the fishy order. Fishy order. Then we have a classical type of discharge, which is creamy discharge, and whiff test positive, So among these 4 things, if 3 or more than 3 are present, that is going to be the classical diagnosis of bacterial vaginosis. So 10% of QH, then the fishy order. Along with that, we have clue cells, and also we have the creamy discharge. That is going to be the bacterial vaginosis. That is going to be the bacterial vaginosis. Clear? Now next to that, remember the vaginal epithelial cells which surround the bacteria. This is called as clue cells. That's what you call what? That's what you call clue cells. That is clue cells. Clear? Now next to that, what is going to be the drug of choice? Drug of choice is metronidazole. Drug of choice is metronidazole. Okay, and we have one question PYQ was asked. Nugent score is calculated in, so remember, Nugent score is also calculated in bacterial vaginosis. Nugent score is calculated in bacterial vaginosis. Clear to everybody? Yes. Now let's Next question. So it was all about candidiasis, trichomoniasis, and the bacterial vaginosis. Now, next question is that a 28-year-old woman presents to the labor and the delivery unit 32 weeks with regular uterine contractions and the lower abdominal pain. She had a history of the previous preterm delivery as well. On examination, cervix is found to be 3 centimeter dilated and 80% effaced, and the fetal fibronectin test is positive. Now, anticipating the preterm delivery, the dose of the dexamethasone given to the mother is. So, whenever we are planning to deliver around 32 weeks plus minus 7 days, so we know that we have to give mandatory steroids for the fetal lung maturity. So, usually give betamethasone and dexamethasone, and we know that these two drugs will act on the type 2 pneumocytes so that surfactant is released and lungs will be mature. Now the question says that what will be the dose of a dexamethasone? So if you remember, I have given you the formula in the main session, that is B2D4. Betamethasone, how many doses? 2 doses. Dexamethasone, how many doses? 4 doses. So what will be the answer? So we have to give 6 mg 12 hourly, 4 doses. How many doses? 6 mg, 4 doses, 12 hourly intramuscular. So let's remember about the fetal lung maturity first. Now, what are the tests that we perform for the fetal lung maturity? First of all, remember we have lecithin sphingomyelin ratio. And lecithin sphingomyelin ratio, it should be more than 2:1. It should be more than 2:1. Next to that, we also check phosphatidylglycerol. We also check phosphatidylglycerol in amniotic fluid. And this is going to be one of the best. And it is suggesting that there is 100% confirmatory fetal lung maturity. Followed by that, we can also check for phosphatidylcholine in amniotic fluid or fetal serum or maternal serum. Followed by that, we have one more test, that is shake test or Nile blue sulfate test. Okay, and if the more than 50 cells are orange, that means lungs are mature. More than 50 cells are orange color, that suggests of the fetal lung maturity. Now, dose of the dexamethasone and a betamethasone. Now you remember B2D4. So how many injections you will give in dexamethasone? So 2 injections. In dexamethasone, 2 injections of 12 mg each. You will give 24 hourly intramuscular. That is going to be the dexamethasone dose. And here you will give 4 injections, 6 mg each, 12 hourly intramuscular. So that is all about the dose of betamethasone and dexamethasone for a fetal lung maturity, Now, next question. A 34-year-old pregnant woman presents for a routine prenatal visit at 36 weeks of gestation. On examination, the fundal height measures small for gestational age. An ultrasound is performed, revealing that there is a reduced amniotic fluid volume and the AFI of 5 centimeters. So ultrasound says that the amniotic fluid is decreased and the amniotic fluid index is going to be 5 centimeters. On examination, uterus reveals a 16-week size. Which of the following is cause above the clinical case? Now, sir, you can see height of the uterus is less than the period of gestation. And why? Because it's a case of oligohydramnios, because USG already revealed that the amniotic fluid is decreased and AFI, amniotic fluid index, is 5. So what is your most likely cause? So what is your diagnosis? So diagnosis of oligohydramnios. So first of all, diagnosis is oligohydramnios. Now, what are the causes of oligohydramnios? It can be a post-term pregnancy, it can be a post-dated pregnancy, it can be something wrong with the kidneys, that is renal agenesis, it can be amniocentesis, it can be IUGR. All these conditions will be related to the oligohydramnios. So here, among these things, what will be the classical cause? So if I talk about the first one, cleft palate, it is a case of a polyhydramnios cause. Just gastrochisis, it's also the cause for polyhydramnios. Gestational diabetes mellitus, polyhydramnios. Bilateral renal agenesis, because something wrong with the kidneys will eventually decrease the GFR, will eventually decrease the fetal urine formation. And when the fetal urine is decreased, sir, it is going to be a oligohydramnios. Because in the earlier pregnancy, it's the maternal contribution for the amniotic fluid, but later on, after 20 weeks onwards, the main contributor of the amniotic fluid is going to be the fetal urine. So anything wrong with the kidneys will eventually lead to the oligohydramnios. Now, what is oligohydramnios? So it is AFI, amniotic fluid index, less than 5 or less than 500 ml of fluid, of amniotic fluid. Clear? Now, what will be the causes? The most common cause usually is idiopathic, but the most common cause for the severe oligohydramnios, it's going to be bilateral renal agenesis. Bilateral renal agenesis. So eventually, when something wrong with the kidneys, eventually will decrease the amniotic fluid. What will be the other cause? Sir, post-term pregnancy. The other cause will be post-term pregnancy. It will be amniocentesis. If we go for diagnostic amniocentesis, it will be related to the leaking as well. It will be related to the IUGR as well. Also, when there is a decreased blood supply to the kidneys in preeclampsia, it will also lead to the decreased GFR. So we have also preeclampsia as a cause of oligohydramnios as well. Or we have a drugs like NSAIDs, or we have ACE inhibitors. All these are the causes for a oligohydramnios or posterior urethral valve. Now, next to that, in case of a complication of severe oligohydramnios, we have a classical triad, which is a Potter's triad, seen with the severe oligohydramnios. Now, what are the three things in this triad? Number first very thing, there will be pulmonary hypoperfusion. Or hypoplasia. Then next to that, so we have next one, that is renal anomalies. So due to the renal anomalies or the kidney problems, GFR is decreased, urine is less. And due to the less amniotic fluid, we will see the baby is having contracted limbs. Now, if you see this triad here, first of all, when there is something wrong with the kidneys, renal anomalies, there will be reduced fetal urine excretion and oligohydramnios causing the fetal compression. When there is pulmonary hypoplasia, it will lead to the respiratory failure as well. And due to this compression, we have also limb deformities. And the features of this baby having a oligohydramnios, you'll see there's low set ears, big nose, prominent epicanthic folds, and downward slant to the eyes. So these are all the features of oligohydramnios. Now, what will be the management? So we have to increase the fetal surveillance. We increase fetal surveillance, continuously monitor, and we can go for amnio infusion. We can go for amnio infusion. Okay, we also give this sandwich therapy with the alanine, fructose and R. So we try to push the pregnancy up to 32 to 33 weeks and then deliver. Okay, what is anhydramnios? When there is absence of amniotic fluid, all the fluid is leaked. Okay, now next, that was all about oligohydramnios. Next question. A 26-year-old primigravida at 30 weeks of gestation came for a regular antenatal checkup. On examination, a uterus corresponding to the 34 weeks of gestation with a normal fetal heart rate. Now here the fundal height is more than the period of gestation because she's just 30 weeks pregnant, but fundal height reveals 34 weeks of gestation. The TVS revealed another finding that the amniotic fluid index is 26. Okay, that means more. Which of the following condition is most likely to be associated? So diagnosis is easy to catch. So diagnosis is simply polyhydramnios. Diagnosis is simply what? Polyhydramnios. Okay, now which of the following will be associated? Now in the previous question just now we have discussed that renal agenesis is a cause of oligohydramnios. Sir, NSAIDs will decrease the urine formation, that is also oligohydramnios. Posterior urethral valve is also oligohydramnios. Cleft lip palate, they are going to cause a polyhydramnios. So renal, NSAIDs and posterior urethral valve, they are cause for oligohydramnios. Now sir, what exactly is a polyhydramnios? Let's understand first. Now sir, in polyhydramnios, if I talk about the AFI, the amniotic fluid index is equal to more than 25, or the volume is more than 2000 ml. The volume is more than 2000 ml. Now, what are the causes for this polyhydramnios? Now, for example, first of all, if there is a twin pregnancy, more amniotic fluid, more urine, more amniotic fluid. Number second to that, sir, if there is some congenital GI anomalies, what will be the reasons? Like atresia, duodenal atresia, esophageal atresia, cleft lip, cleft palate, gastrochisis, they are all related to the polyhydramnios. Or in case of a gestational diabetes also, there will be what? Polyhydramnios. So what will be the cause? If the most common cause you ask, so that is going to be the idiopathic, but most common cause for the severe polyhydramnios, that is going to be the congenital GI anomalies. So what are the causes? First of all, we have gestational diabetes. We have gestational diabetes. Followed by that, we have twin pregnancy. Followed by that, we have twin pregnancy. Followed by that, we have cleft lip, cleft palate. Cleft lip, cleft palate. Then we have esophageal or duodenal atresia. Esophageal or duodenal atresia. Or we have gastrochisis as well. If omphalocele is that, वहाँ पे covered होगा sac में components, and here it will be open. Sign and symptoms. Now what will happen? So due to this polyhydramnios, there will be the decreased tone, and it will cause also respiratory discomfort to the mother as well. So mother will have dyspnea, will have orthopnea, and respiratory discomfort. Respiratory discomfort. And also complication. What can be the complication due to this? Due to the over distension of the uterus or the large uterus, the tone will decrease and it can lead to the postpartum hemorrhage. है ना? Atonic uterus. Now what will be the treatment? Sir, will give drug indomethacin. Will give a drug indomethacin 25 mg. This indomethacin will decrease the urine output. This will decrease the urine output and further the amniotic fluid levels will decrease. But remember, do not give beyond 32 weeks. Do not give beyond 32 weeks. Why? Because it will lead to the premature closure of ductus arteriosus. It will lead to the premature closure of ductus arteriosus. And also, guys, we can go for therapeutic amniocentesis. Usually we do this therapeutic amniocentesis. Therapeutic means when you're using amniocentesis as a treatment. Okay, diagnostic means when you diagnose something. Now you will usually do this therapeutic amniocentesis when the AFI is more than 40. When the AFI is more than 40. When the AFI is more than 40. Is that clear? Now amniotic fluid is maximum around how many weeks? It is maximum around 32 to 34 weeks. And so if 36 weeks AFI is less than 32 to 34 weeks, at 36 weeks AFI is less than 32 to 34 weeks, so around 36 weeks we can go for external cephalic virgin. We can go for external cephalic virgin. Clear to everybody? Yes. So that's all about the amniotic fluid disorders, oligohydramnios and polyhydramnios. Now let's move to the next question, bache. A 58-year-old multiparous lady presents to the gynecology clinic with the complaints of the mass descending per vaginum. She's coming with the complaints mass descending per vaginum. On examination, you note that the external os lies at the level of introitus. So she's 58-year-old multiparous lady. Okay, she's coming with the mass descending per vaginum, and you note on examination that external os lies at the level of introitus. What is the degree of the uterine prolapse? Write down in the chat box, anybody. What will be the degree of the uterine prolapse? What will be the degree of uterine prolapse? Yes. Now, if you remember the Shaw's classification of a uterine prolapse, we have discussed that first degree, second degree, third degree, and the procedentia, depending upon the descending of the cervix, right? So what will be the degree of uterine prolapse when the external os lies at the level of introitus? So it is going to be very good. It is going to be second degree. It is going to be second degree. It's going to be second degree. Now let's understand first a little bit of uterine prolapse. Then the management of the uterine prolapse is going to be one of the most important chapters from the gynecology. Okay. Now, sir, first of all, we have the support of uterus. Now, what are the ligaments support the uterus? So ligaments that support uterus. Okay, so we have a important triradiate ligaments. And what are these ligaments? Number first, we have a cardinal ligament. We have a pubocervical ligament. We have a pubocervical ligament. And we have a uterosacral ligament. Uterosacral ligament. And all together, this cardinal ligament, it is also called as transverse ligament. I will write T, and it's all three together, they are called as triradiate ligament. They are called as triradiate ligament. And if one of the best support of the uterus, which ligament support best uterus, that is going to be cardinal ligament, transverse, or McEnroth's ligament. Now the muscles that support the uterus, the best muscular support to the uterus, best muscle to support the uterus, that is going to be levator ani muscle. That is going to be levator ani muscle. It makes the pelvic floor. Okay, na? Other muscles, we have superficial transverse perineal muscle, deep transverse perineal muscle, and the bulbospongiosus. The same muscles, bache, that we have resected in the episiotomy. Same muscles, my dear students, that we have resected in the episiotomy. So that is the best muscle to support the uterus. Clear? Now, sir, which of the following is not the true support of which of the following is not the true support? Answer will be broad ligament. Now the question that comes is, what will be the features of these patients? What will be the features of these patients? Now, first of all, what can be the most common cause for prolapse? Most common cause for prolapse is going to be abnormal conduct of labor. Most common cause will be abnormal conduct of labor. Okay. Now, what can be the other causes? What can be the other causes? What can be the other causes? So, if a patient is having increased abdominal pressure, okay, or if a patient is having some connective tissue disorders, or if a patient is a post-menopausal, okay, these can be the other causes for a uterine prolapse, okay, or if there is any pelvic floor dysfunction as well, all can be the other causes for the uterine prolapse, and a lady who had a multiple vaginal deliveries. But the most common is going to be abnormal conduct of labor. Now, what will be the features of these patients? Now, first of all, this patient will complain, I'm feeling something is coming out. So that's what here a patient says, that there is mass descending per vaginum. There is mass descending per vaginum. Followed by that, other complaints. Now, these ligaments that support the uterus, once this uterus is descending down, there will be stretching of these ligaments, and stretching of these ligaments will lead to the back pain on the patient, and patient will say, doctor, when I'm lying down, the pain is relieved, but when I'm standing, at the end of the day, the pain gets worse. The pain gets worse. Now, followed by that, what will be the feature as well? Now, this lady who's having this prolapse, anteriorly the bladder will be compressed, so vagina will go into the bladder, that is cystocele, and posteriorly rectum is there, so there will be features of cystocele as well as rectocele as well. Now, next to that, what will happen also? Now, when this cervix is going down into the vagina, on the dependent part, there will be a ulcer, which is a non-healing chronic ulcer, a decubitus ulcer. And this ulcer, it will not be due to the friction, it will be due to the venous congestion. Remember that the ulcer in prolapse, the dependent part, it is due to the venous congestion, not due to the friction. And the treatment for that is ecriflavine. Treatment for that is ecriflavine. Clear? Now, these features, something coming out, features of cystocele, rectocele, mass descending down, something coming out, okay? All these are the features of the prolapse. Now, support of the uterus is clear, clinical feature is clear, cause of the prolapse is clear. Now, the main question that the examiner can ask is going to be the management. Now, we have a classification called as Shaw's classification, which says that first degree is descent of the cervix in the vagina. Second degree, it's descent of the cervix to the introitus. Third degree, it is descent of the cervix outside the introitus. And procedentia, all the uterus is outside. All of the uterus is outside the introitus. This classification is called as a Shaw's classification. This classification is called as a Shaw's classification. Clear to that? But one more classification we have, which is called as a PYQ classification, and in FMGE that was asked, what is the reference point of PYQ's classification? What is the reference point for the PYQ's classification? Now, if I talk about the PYQ's classification, the reference point is hymen. The reference point is hymen. Reference point is hymen. Okay, now above hymen, negative, at the hymen, 0, below hymen, that is grade 2. Are you getting my point? So that is a PYQ classification. So stage 1 of PYQ classification, that is above hymen. Stage 2 of PYQ classification, sir, at hymen. Stage 3 of PYQ classification simply is beyond hymen, that is more than 1 centimeter down from the hymen. And stage 4 is complete prolapse, which you call procedentia. That is a PYQ classification as well. So stage 1 above the hymen, more than 1 centimeter above the hymen. Stage 2, at hymen. Stage 3, beyond the hymen, less than 1 centimeter below the hymen. Stage 4, complete prolapse. That is which classification? PYQs classification. PYQs classification. And this is what? Shaw's classification. So at the level of introitus, it is going to be 2nd degree. Now anterior vaginal wall, it will affect the bladder. It will involve the bladder. So patient will have the cystourethrocoele. Okay. Posterior vaginal wall को include करेंगे. So there will be a enterocoele and rectocoele. Enterocoele and rectocoele. So what to do further? Sir, when the descent of the vagina, when the descent of this uterus is down on the anterior side, if it is involving the bladder, there is cystocoele. So for the cystocoele, we go for the anterior colporrhaphy, and for the rectocoele from posteriorly, we go for posterior colpoperineurrhaphy, and together we call it as a pelvic floor repair. Together we call it as a pelvic floor repair. Now if the examiner will mention the question, a female is coming, a young lady with the prolapse, and there is urinary retention as well due to this descending of this uterus down, what will be your first management? Remember, always first management, we go for a ring pessary. First management, we go for a ring pessary. First management, we go with a ring pessary, so that she will have a temporary relief. Then only you will decide whether you have to go with the hysterectomy, whether you have to go with the sling surgeries, or whether you have to go with the Manchester repair or the Fothergill's repair. Now let's understand. We have 3 ladies. First of all, a lady, she's in the reproductive age group and she wants a future child. Second, a lady, she's in a reproductive age group but the family is complete. Third lady, she's postmenopausal, family is complete. Fourth lady, she is postmenopausal but she has a contraindication to the surgery. Now 4 ladies, 4 different types of treatment. Now if elderly woman is there, the treatment of choice for elderly woman is going to be vaginal hysterectomy with pelvic floor repair. Vaginal hysterectomy with pelvic floor repair. Now in pelvic floor repair, what does that mean? Just now for cystocoele, anterior colporrhaphy; for rectocoele, posterior colpoperineurrhaphy. So, and this is also called as Ward Mayo hysterectomy. It is also called as Ward Mayo hysterectomy or Ward Mayo operation Next to that, sir, what exactly we do? We go for anterior colporrhaphy, for cystocoele, and posterior colpoperineurrhaphy for rectocoele. Posterior colpoperineurrhaphy for rectocoele, and together anterior colporrhaphy plus posterior colporrhaphy we call is at pelvic floor repair. We call it as a pelvic floor repair. Clear to everybody? We call it as a pelvic floor repair. Now next to that, if anterior colporrhaphy sometimes not done properly, it can cause stress incontinence in 2 to 3 weeks. Yes, it can cause, because in stress incontinence, what exactly is the main reason? There is an involuntary escape of the urine, okay, during the strenuous activities. For example, if a patient is sneezing, patient is coughing, what will happen? Patient will cough, sneeze, and patient will urine followed by that. So under the pressure activities, if a patient is having involuntary escape of the urine, that is going to be a stress incontinence. And the most common cause for that is going to be a bladder neck descent. Okay. Now what is the treatment for that? हम bladder neck को ऊपर करेंगे. Either we go for the transobturator tape, transvaginal tape, or transobturator tape. Okay. Tension-free vaginal tape or tension-free transobturator tape. Or also we can go for the bird sutures. We lift this bladder neck to the proximal urethra, okay, and we ligate it, okay, and that procedure is called as Birch colpo suspension. Okay, these are the classical treatment for the stress incontinence. Okay, so it can be seen also the stress incontinence. Now next to that, we have a further grill repair or Manchester repair. It's for reproductive age group. It is for reproductive age group. The family is complete. Family is complete. So we go for two steps. We do the amputation of the cervix. We do the amputation of the cervix and we do the plication of cardinal ligament. And we go for the plication of cardinal ligament. This is a treatment. This is the treatment for the woman of reproductive age group having the prolapse, Manchester repair or the Fothergill surgery. Okay. Now next to that, we do the Fothergill stitch as well. What is that? So that is a bilateral McEnroe's ligament. Bilateral McEnroe's ligament ligated to the uterus anteriorly. Ligated to the uterus anteriorly. Okay, that is Fothergill repair or Manchester repair. Then we have a sling surgeries. It's for the women of reproductive age group who want a future child. So we go for the sling surgeries. So this is treatment for young ladies, future child, who want future child. And we have a different types of sling surgery. We have a Shirodkar sling surgery. We have Khanna sling surgery, or we have Purender sling surgery. So this is all about the treatment. If a young lady is coming, she's having a plan for the future child, go with the sling surgeries. And old lady, if old lady contraindication to surgery, that means she's having increased blood pressure, she's having other features, for that we go for Lefort's colpoclesis. We go for Lefort's colpoclesis. That is about the treatment for the young ladies. Clear to everybody? Yes. Chalo. Now next, sir, a pregnant lady having 2-year-old child had come for the ANC checkup in second trimester. The recommended dose for TT. Now for a primi gravida, remember, for a primi gravida, how many doses we are giving? 2 doses. First, remember, for primi gravida, we are going with a 2 doses. And how exactly you will give these 2 doses? So the first dose for primi gravida I will give as soon as possible. And a second dose for this primi gravida I will give 3 weeks prior estimated date of delivery. 3 weeks prior estimated date of delivery. 3 weeks prior estimated date of delivery. Is that clear? Now, if it is a case of a multi-gravida, if this is a case of a multi-gravida, okay, and the last childbirth is within 3 years, give 1 dose. Last childbirth is more than 3 years, give 2 doses. Is that clear? So that is about this pregnant lady dose of TT. So she had a 2-year-old child, so less than 3 years. So you give 1 TD booster. You give TD booster. Is that clear to everybody? Yes. So that's all about the recommended dose for TT. Next question. A 19-year-old girl comes with a 3 months of amenorrhea, and she's having excessive vomiting. The blood pressure is 110 by 70. On per abdominal, the fundal height is 18 weeks. The doctor advised the USG. The image is given below. What will be the management? So a lady is coming to you with the complaints of a vomiting, excessive vomiting. That means there is an hyperemesis. Why this hyperemesis is there? Because of increased beta HCG. Because of increased beta HCG. Followed by that, this lady is having 3 months amenorrhea, and the fundal height is above the period of gestation, that is 18 weeks. That is how many weeks? 18 weeks. Now doctor advised the USG. This is the USG. What will be the management? Now this USG with a classical appearance called as snowstorm appearance. क्या बोलेंगे इस appearance को? I call it as snowstorm appearance, or we call this appearance as cluster of grapes appearance. We call this appearance as cluster of grapes appearance. Clear? Now, sir, what will be your diagnosis? This is a diagnosis of hydatiform mole, or which is also called as vesicular mole, or we also call it as complete mole. Okay, and there is abnormal proliferation of the degenerated chorionic tissue due to the abnormal fertilization. Okay, it's a benign condition, but if it's not treated, it can turn into the malignancy, right? And now what will be the management for this? So the management for this is suction and evacuation. The management for this is suction and evacuation. Now let's understand that what are the features of this complete mole. First of all, sir, this patient, they complain of a bleeding per vaginal. These people complain of the bleeding per vaginal. Followed by that, sir, there is increased beta HCG. There is increased beta HCG. Okay, and then other than that, these have hyperemesis. These patients have hyperemesis, which can also lead to the hypokalemia and metabolic alkalosis. Metabolic alkalosis. Now the subunits of the beta HCG and the thyroid are same. That's why in complete mole there can be thyroid toxicosis seen as well. Thyroid toxicosis seen as well, and also the fundal height. The fundal height is more than period of gestation, and respiratory distress can be seen as well. Respiratory distress can be seen as well. So these are all the features of the complete mole. So not painful, vaginal bleeding will be there. Along with that, hyperemesis, fundal height is more than the period of gestation, and increased beta HCG levels, right? Now, sir, what will be the management of this vesicular mole or the complete mole, bache? Sir, first of all, so we go with a suction and evacuation. We go with suction and evacuation. Followed by that, we can also go for slow curettage. We can also go for slow curettage. Okay. Now next to that, sir, we also do USG. We also do USG to check the retained beds. We also do USG to check the retained beds. Next to that, do chest X-ray as well. Do chest X-ray as well to rule out lung metastasis. To rule out lung metastasis, and this lung metastasis, if seen, the FIGO classification of gestational trophoblastic neoplasia says that at stage 1, this is confined to the uterus only. At stage 2, it is around the uterus. Okay, at stage 3, it goes to the lungs, and at stage 4, all other metastatic sites. So which stage of FIGO classification explains the cannonball metastasis? That is stage 3 of FIGO classification. And what is this appearance called as? This is a cannonball metastasis. This is a cannonball metastasis. Clear? And this has been asked image-based question. And kaun se stage of FIGO classification is there? Stage 3. It's stage 3. Now next to that, sir, this patients who have this complete mole, we continuously follow up for beta HCG levels. Follow up beta HCG levels for how long? For how long you'll follow up? For the 6 months. For the 6 months. But if age more than 40 and family is complete, then go with a hysterectomy. Then go with a hysterectomy as the answer. Clear? So that is all about the management of the complete mole. That is all about the management of the complete mole. Okay. Now, sir, we have a complication of this. We have the complication of this, which is called as gestational trophoblastic neoplasia. Because if you left this untreated, it can lead to the malignancy. And what are the complications we have? Remember ICP, that is invasive mole. Next one is choriocarcinoma, and we have a placental site trophoblastic tumor. We have the placental site trophoblastic tumor. Now, bache, invasive mole, beta HCG, choriocarcinoma, you will follow for the beta HCG, but here you will follow for HPL, human placental lactogen. You'll follow a marker is going to be HPL. Okay. Now, sir, what will be the treatment for gestational trophoblastic neoplasia? If I talk about the management is the key that you have to remember. Management is the main part. Now, for the management for low risk, remember, for the management for low risk, which patient should be considered at the low risk, जिसका score less than 7 होगा. Clear? For those, if the score is just mentioned less than 7 at the FMGE level, think of it, it's a low risk. Okay, you think of a one drug only, you will give single agent multi-dose treatment. Single agent multi-dose treatment, and that is going to be methotrexate. That is going to be methotrexate. Okay, 1 mg per kg plus folinic acid. If for high risk treatment is asked, score is more than 7, then remember IMACO regime. Now, what is this IMACO regime? Etoposide. Okay, M is methotrexate. Then A is actinomycin. C is cyclophosphamide, which causes hemorrhagic cystitis as well. And O is oncovin, which is called vincristine as well. So remember this IMACO regime as well. Clear? So that is all about the management. Gestational trophoblastic neoplasia is going to be important question Well, low risk के लिए methotrexate only on day 1357 1 mg per kg, one single chemotherapy agent, but with the multi-dose treatment, with a multi-dose regime, that is going to be the methotrexate. If a score is more than 7, okay, so we are giving a IMACO regime. E is etoposide, M is methotrexate, A is actinomycin D, C is cyclophosphamide, O is oncovin or a vincristine. So that is all about the gestational trophoblastic neoplasia complication. Clear? Now next, the given instrument used is, what is this given instrument in the picture? Sir, it is Doyne's retractor. It is used at the time of what? Cesarean section. And a cesarean section, so that there is a better visualization of the internal organs or the abdominal organs. Okay, na? So that is going to be a Doyne's retractor. Okay. Now the last question. A 14-year-old girl with a rapidly enlarging abdominal mass. Imaging revealed that there is a large ovarian tumor. So you have first thing, 14-year-old girl, she's having an abdominal mass. There's a large ovarian tumor. The lab investigations shows the markedly elevated serum alpha fetoprotein levels. Now alpha fetoprotein levels are raised. What is your most likely diagnosis? Very good. The most likely diagnosis is going to be, in the chat box, it's going to be endodermal sinus tumor, which is also called as yolk sac tumor, Sir, why not choriocarcinoma? इसमें beta HCG raised होगा. Sir, why not granulosa cell tumor? Inhibin will be raised, and more precisely inhibin B. B is better. Dysgerminoma क्यों नहीं होगा? There is increase LDH raised. Now talking about the ovarian tumors, we have epithelial ovarian tumors, we have a sex cord ovarian tumors, and we have a germ cell ovarian tumors. If the question says most common ovarian tumor in the reproductive age group, your answer is going to be a teratoma, dermoid cyst. If the question asks most common in the older age group, your answer is going to be the serous cyst adenoma or the epithelial ovarian tumor, right? Now let me tell you about these ovarian tumors. Each of the following, what can be the question asked? Either they will ask these intracytoplasmic inclusion bodies or the bodies which are seen in these ovarian tumors, or either they will ask these markers for these ovarian tumors. So like in this question, LDH was raised, AFP was raised, it was endodermal sinus tumor. If it would have been inhibin raised, it was granulosa cell tumor. If it was the LDH raised, it was dysgerminoma. Okay, so let's talk about the first ovarian tumor, serous cyst adenoma. You will remember that it's some type of a epithelial tumor seen in older age group, and we see samoma bodies in serous cyst adenoma. If it is a mucinous cyst adenoma, remember this is associated with pseudomyxoma peritoni. Excessive mucin there. If it is a Brenner's tumor, it is associated with a pseudomag syndrome. All these first three tumors, they are a type of epithelial tumors. What is pseudomag syndrome? This is going to be Brenner tumor. That is going to be pleural effusion and ascites. What is Meg syndrome? That is fibroma ovary. Next to that, we have pleural effusion and ascites. Next to that, what is teratoma? It's a type of a most common type of the tumor in pregnancy, and the most common tumor goes under torsion. Okay, and it's a type of a germ cell tumor made up of 3 layers. That is endoderm, ectoderm, and mesoderm. And it's a type of a germ cell tumor, and it's the most common tumor to undergo torsion, and the most common tumor that is seen in pregnancy. Now we have a mature teratoma, which is a benign, and we have immature, that is a malignant. Remember, mature teratoma mature teratoma is benign and immature teratoma is going to be malignant. Okay, and do remember 90% it is benign. 90% it is benign. There is no marker for this teratoma. Okay, next to that, what is dysgerminoma, guys? Remember, in dysgerminoma we have increased LDH levels and we have increased PAP, that is placental alkaline phosphate, that is placental alkaline phosphate. Okay, next to that we have yolk sac tumor. In yolk sac tumor we have increased alpha fetoprotein, we have increased alpha 1 antitrypsin, we have increased alpha 1 antitrypsin, and the classical bodies which are seen are Schiller dual bodies. This slide is going to be one of the most important among all slides. One question will come from this slide. Then the next one is a granulosa cell tumor. The marker is going to be inhibin, and more precisely inhibin B. This is an estrogen secreting tumor. That's why it is also related to the endometrial carcinoma and precocious puberty as well. And this granulosa cell tumor, we have the bodies called as CAR Exner bodies. What are the bodies seen? We have CAR Exner bodies. So remember that serous cyst adenoma, Samoma bodies, mucinous cyst adenoma, seromyxoma peritoni, Brenner tumor, seromyx syndrome, teratoma, all three layers, most common germ cell tumor. And the picture of teratoma was asked that it is a mature cystic teratoma, and we have this rocket tank C protuberance on the image. Okay, na? And you will see the mature is a dermoid benign cyst, immature is a malignant one, and inside you will see there is hair and teeth like structures, with a dermoid cyst or teratoma. Okay, next one, guys, core Exner bodies. You can see that core Exner bodies, this coffee bean nuclei, it is seen with the granulosa cell tumor of the ovary, and it has increased estrogen, this granulosa cell tumor, and associated with endometrial cancer. And marker is going to be for this inhibin B or inhibin. You can just mark inhibin also. Okay, so this is about two images. These are core Exner bodies. Okay, same rosette shaped bodies are seen also in the retinoblastoma. Remember, flexular interstitial rosettes. Okay, next to that, Schiller dual bodies seen in yolk sac tumor, which is also called as endodermal sinus tumor. And which levels are increased? Alpha fetoprotein levels are increased. Okay, the central vessel surrounded by tumor cell and the whole structure being contained in a cystic space often lined by tumor cell. That is Schiller dual bodies. Next to that, serous cyst adenoma. What do you see, guys? Samoma bodies. And serous cyst adenoma, it is a type of an epithelial ovarian tumor. Number second, sir, it is seen with an older age group. It is seen with older age group, and these Samoma bodies are also seen. No need to mention, you already know that. Chalo. Papillary thyroid cancer, meningioma, mesothelioma. Next to that is dysgerminoma. Bache, dysgerminoma, we have a fried egg appearance, which is also called as, we have these seminoma type cells. We have these seminoma type cells, and this dysgerminoma, it is associated with the increase LDH. It is associated with increase LDH. Okay, nests of cells are separated by the fibrous septa, and septa is infiltrated by the lymphocyte. So lymphocytic infiltration. Clear? Next to that, we have a Brenner tumor associated with these coffee bean nuclei and Volthard cell nest, and it is associated with a seromyx syndrome as well. So there is hyperplastic fibromatous matrix with a nest of epithelioid cells showing the coffee bean nuclei pattern. So coffee bean nuclei pattern seen with the Brenner's tumor. So this imaging can be asked as well from the ovarian tumors. Clear to everybody? So remember with this short points that LDH, these three, LDH with dysgerminoma, alpha fetoprotein with the yolk sac tumor, and the granulosa cell tumor, that is inhibin B. Now, one more question that can be asked from these ovarian tumors, I will write here, that is a tumor secondary to ovaries. Now, if the tumor secondary to ovaries, what does that mean, Bachit? So that means the tumor metastasized from some cancer. Which cancer it metastasized from? It can be metastasized from the breast cancer or the stomach cancer or the gastric cancer. If you have to choose first one, choose stomach, next choose breast cancer. And we have a classical type of cells over there called as signet ring cells. And can you name the tumor? Very good. So that the tumor is called as Krukenberg's tumor. That tumor is called as Krukenberg's tumor. Is that clear? So that is going to be the one more ovarian tumor. Next to that, the last question of the day and the last part. What is the most common ovarian tumor to have? The seromyxoma peritonei. When this serous mucinous cyst adenoma ruptures, it releases a lot of mucin. Okay, and that's what you call seromyxoma peritonei. So which ovarian tumor is associated with a seromyxoma peritonei? Write down in the chat box. So very good. That is going to be mucinous cyst adenoma. That is going to be mucinous cyst adenoma. Okay, about the serous cyst adenoma, you remembered psammoma bodies and epithelial type. Okay, about the dermoid, you remember it is a mature teratoma, all three layers and hair and plate-like structures. About the Brenner tumor, you remember pseudomake syndrome, which is pleural effusion and ascites and a pseudomake and a Brenner tumor. So that is all about the ovarian tumors as well. Is that clear to everybody? Yes. So we have tried to include all the important chapters that can be asked in your exams. Okay. Even though after that, if you have any single doubts related to the studies, you're most welcome to ask me on the Telegram. Till 22nd, Telegram is banned, but eventually after 27, you can ask any doubts. So do remember all the topics that we have discussed in part 1 of the revision and the part 2 of revision. Clear? So about the PDF, guys, Telegram is banned. I hope that the team Meduhub, they will arrange some Google Drive link and they can attach in that comment section as well. Anything else to ask? You can ask in the chat box. Yes. So do remember the markers followed by that treatment of the prolapse and then all the important chapters that we have discussed. GDM, hypertension in pregnancy, okay? Antepartum hemorrhage, postpartum hemorrhage, abortion, ectopic pregnancy, labor, types of the pelvis and all. So just few days to go for the exams. It's 19th already. So we are just few days away. Remember that. Do not compare yourself with anyone. Run your own race, okay? Revise, give the grand test, the last one lap. Revise your mistakes that you have been doing from last 3 to 4 months, okay? Focus on the path which you are weak at right now these days. Revise that stuff more, okay? Do not discuss anything after the paper 1, okay? Do not change your answers as well. You have been studying from last 5 months. Okay, nobody knows you better than yourself. So in case any doubts, you're most welcome. Thanks for being interactive. And I hope both the part 1 and part 2 will be useful for your exams. Clear? So keep learning, keep shining. Okay, the world is waiting for your beautiful contributions coming up. Pass the exam and give the best shot. Till then, take care. Goodbye. Allah Hafiz.